muscles problem, for example, they have bruxism, yeah, or whether they have a lot of twitchings, yeah. So sometimes whether they have restless leg syndrome, yeah. So those movement we can detect via EMG. So we have EEG, we have EMG, we have ECG, yeah. And we have EOG, electrooculogram, yeah, where we can identify the eye movement, whether is it rapid eye movement during sleep, or is it awake, or is it reading eye movement, or is it blinking eye movement. All this we can detect from the EOG. Yeah, so basically polysomnogram is a very comprehensive sleep test that we can use to detect all this important information in order to help us gather and diagnose obstructive sleep apnea disease. Yeah. Okay, so this is roughly how polysomnogram reporting looks like. So this is the example of rapid eye movement that you can see from the EOG, yeah, electrooculogram. So we have left EOG, we have right EOG. Yeah, so this is how rapid eye movement looks like during REM sleep. Yeah, yeah. So you can also see this multiple brain wave here, EEG, that we can detect from our EEG. Yeah, so this EEG electrodes actually being placed at multiple area, at the central area, at the occipital area. Yeah, so all this area will be able to detect all these brain activities, which will represent certain stage of sleep. Yeah, because certain stage of sleep can be associated with certain sleep disorder. Yeah, and obstructive sleep apnea, yeah, they tend to occur during REM sleep as well. Yeah, so this can help us to gather more info, and you can also see the chin movement. You can see chin on your left hand side there. So the chin movement tend to be flat, and not much of muscles movement during your rapid REM sleep, yeah, rapid eye movement sleep, because during REM sleep our muscles tend to totally relax. So that's why you can see the chin movement is almost zero here, straight line, and very minimal movement there. And you can see the ECG, the electrocardiogram here, showing us sinus rhythm. Yeah. So from your ECG, actually you can see whether is it any bradycardia event, any tachyarrhythmia event, yeah, any VT, any VF. You can also see from PST, from our polysomnogram. Yeah. And you can also this snoring parameters here. You can also see the thermistor level here. This is actually the airflow. Yeah, we detect the airflow, whether is there any airflow reduction. So you can see this is how a normal airflow looks like. This is when the airflow is actually reduced up to about 20 to 30% here. So there might be some hypopnea event happen somewhere around here as well, but you can't really identify properly here. You need to have a proper PSG. Yeah, PSG can be recorded within 30 seconds, 60 seconds, or 30 minutes, 60 minutes epoch. Yeah. And you can also look at this thoracic and abdominal movement here. So this thoracic and abdominal movement can be detected from the sensor belt. The belt just now that we put on the chest and the belly, it can detect the thoracic wall movement and the abdominal wall movement, which may help us to differentiate whether this is obstructive sleep apnea or whether this is central sleep apnea. Yeah, you can also see the SpO2, the oxygen saturation level here. Yeah, so usually in OSA patient, yeah, they tend to have low oxygen saturation, yeah, when they have apnea or hypopnea events. Yeah, and you can also see the heart rate. So you can see this patient is a bit bradycardic. Yeah, heart rate is 43, 45. Yeah, yeah. So this is how roughly polysomnogram recording looks like. So yeah, so for a sleep specialist, it is very important to be able to identify all these important parameters in order to diagnose OSA. Yeah. Okay, so this is again the type of sleep study that I mentioned earlier. Yeah, we have type 1, type 2, type 3, type 4 sleep study. The gold standard, the most comprehensive, the best sleep study is type 1, which is done in the sleep lab attended by a sleep technician. Include minimum 7 parameters, include EEG, EOG, chin EMG, airflow, respiratory effort, oxygen saturations, and ECG detector. Okay, and then we have sleep study type 2, minimum of 7, include EEG, EOG, chin EMG. But the difference between 1 and 2 is that 1 attended by sleep technician, 2 is not attended by sleep technician. Yeah. Then level 3, they usually use minimum of 4 channels, yeah, include ECG, heart rate, oxygen saturation, 2 channels for respiratory effort, yeah, or 1 respiratory effort channel, yeah, attended or unattended by a sleep technician. You can see the difference is basically the number of channels, yeah, only 4 channels in type 3 sleep study. And type 4 sleep study is the lowest type, the least accurate type, only 3 channels being used. Yeah, they check for airflow, include actigraphy, oxygen saturations, and peripheral arterial tone, can be attended or unattended by a sleep technician. So this is important. I think as a GP, if you have some interest in sleep study, you can actually liaise with our sleep technician to order probably type 2, 3, or 4, yeah, because these 2, 3, 4 can be done out of sleep lab, can be done at home by using home sleep apnea testing. Okay, so basically my topic is basically to discuss on the screening and diagnosis part. So the treatment part and the complication part will be covered by other speakers, but just as a rough idea, important treatment is lifestyle modification, yeah, dietary changes, yeah, one quarter half method of dieting, yeah, quarter potatoes, brown rice, bread or pasta, quarter chicken, fish, beans or eggs, yeah, quarter protein, quarter carbohydrate, and half fruits and vegetables. Yeah, lifestyle modification is important. Usually we will, for my OSA, multi-moderate, we will advise them to do lifestyle modification first for 3 months. If let's say lifestyle modification fail, then you probably want to, you know, subject them for like CPAP or bariatric surgery or other form of treatment modality. Treatment CPAP, yeah, this will be covered by other speakers, but just for a rough idea and rough introduction, this is how CPAP looks like. Yeah, continuous positive airway pressure. It can help to open up the airway during sleep. Yeah, you also have this positioning technique. Yeah, for multi-moderate OSA, you can ask the patient to do proning positioning technique, whether sleep on the right side or on the left side, because usually the airway tends to collapse more if the patient is lying on a supine position. Yeah, so on the lateral position, the airway collapse are not really that significant. Tennis ball technique means that put a tennis ball here, so patient will not be able to lie supine. When they lie supine, they will feel uncomfortable. Yeah. Okay, complications will be also covered by other speakers, but just as a rough introduction. OSA can lead to a lot of comorbidities, a lot of complications, yeah, coronary artery disease, heart failure, arrhythmia, hypertension, stroke, yeah. And again, these are the adverse effects of OSA: hypoxia, intermittent hypoxia, glucose intolerance, lipid abnormalities, hypercoagulability, altered vascular hemolysis. Okay, so this is my last slide. I would like to thank everyone for your participation and your attendance and your concentration. I would like to open the floor for any Q&A. If you have any question that you want to ask, you can, you know, share it with us so we can try to discuss it together. With that, I thank you.
Of OSA, due to our limited time, if there is any question from the floor and also our virtual participant, kindly type down your question in the QA box, in the chat box, and Dr. Yakin shall answer them in the chat box. Thank you again, Dr. Yakin, for joining us today virtually. Moving right along, it is now my pleasure to introduce our next guest speaker, Dr. Raymund Das, anak lelaki Maria Das. Dr. Raymund Das is a consultant pulmonologist and internal medicine in Hospital Tuanku Jaafar Negeri Sembilan. He is a member of Malaysian Association of Oncology and Interventional Pulmonology, member of Malaysian Thoracic Society, Malaysian Medical Association, and an ad hoc member of the European Respiratory Society. He is involved in studies on respiratory disease and heart failure. Ladies and gentlemen, please join me in welcoming Dr. Raymund Das, who will be joining us virtually today for his speech on NIV and other treatment modalities in OSA. The floor is yours, Dr. Raymund.
Thank you very much to the organizing committee. Just give me a minute until I share my slides here. Okay, so my task today is regarding NIV and other treatment modalities in OSA. I just want to thank Dr. Yakin just now because she spoke very well.
We couldn't hear you.
Is it okay? Can you see me? Can you hear me?
Yes, Dato.
Okay, lovely. All right. I'm so sorry. Okay, so my task today is NIV and other treatment modalities in OSA. Okay, so this is the outline of my presentation. I just want to thank the organizing committee for allowing me to speak on NIV and as well as other modalities. Yeah. So earlier, Dr. Nurul has highlighted to us regarding what's OSA, the pathophysiology, the definition, how you diagnose, and a little bit of about the treatment. So my task today is to go a little bit deeper in the treatment of OSA and what are the options that we have available in Malaysia. So some of the treatment management, we don't have it in Malaysia, but however, I think this is something that we should look forward to, especially in the coming ages where it's getting more obvious and more rampant, and even nowadays patients are getting very in touch with the outside world, and they may come and ask us regarding what this means and all that. So as a primary care physician, I think we should be aware of what are the treatments which is available, and we can we can refer the patient to our physicians or pulmonologists or sleep physicians and all that. Yeah. So it will be initially it's going to be a bit on positive airway treatment. That is our CPAP. So I also be talking a little bit about what are the other alternatives for CPAP, which just now Dr. Nurul has pointed out that we can have some treatment based on positional therapy, nasal expiratory positive airway pressure, oral pressure therapy, oral appliances, surgical treatment, and of course the newer therapeutic options. Yeah. So now a little bit on I don't want to dwell too much on this because Dr. Nurul just now highlighted regarding OSA. How do we diagnose OSA? We have this index called AHI index, apnea hypopnea index. This is the index that we use to familiarize ourselves into how severe, what is the severity of the OSA, mild, moderate, or severe, and based on this, so we will decide on the treatment. So now, the prevalence of OSA in Malaysia is roughly about 15%, and 15% is quite high actually. If you look at other countries like Australia or countries like New Zealand and all that, okay, you believe it or not, the prevalence is almost similar or probably a little bit lesser, but we have always been champions in terms of obesity. So 15%, I think it's still an underestimate, but this is the figure that we have right now, and it's more predominant among males. So what happens is that the person has got OSA, he will suffer from hypoxemia, hypercapnia, fragmented sleep. So we also have exaggerated fluctuations in heart rhythm. Yeah. Also, the BP becomes a little bit difficult to control, and also increases the intrathoracic pressure, right? And of course, the long-term sequelae, if we're just going to leave it as such, and if we're not going to treat OSA, we're going to get a refractory hypertension. So as a primary care physician, if you see patients whose BP is not very well controlled, if you notice that the patients are already on 3, 4, or 5 antihypertensive, and you find it very difficult to manage the blood pressure, please look into the patient's sleep, try to do some scoring, and then you'll be surprised that this patient may have OSA, right? The patient may or may not be obese. The patient may be with a normal BMI, but yet due to some facial or anatomical configuration, they may have OSA, right? So it is important to look at patient overall, right? And we also have cardiovascular comorbidities, cognitive function. This is very important because we notice that all of them, they don't perform that well in the offices. a simple executive function cannot be done properly, you notice that it's going to take a very long time for a person to solve problems which could be very trivial. So these are also some of the effects of OSA which is not treated: poor mood, and of course, it's premature death, right? In terms of health economics, we have some data from Malaysia. So this was in 2009. So what they've done is that they noticed that the cost which incurs for an OSA patient is similar to one's the diabetes patients, right? So you must understand that diabetic patients along the way, there's a lot of cost incurred in treating them because of the complications and all that later on. So the cost, if you calculate on the long term, it is similar. So that's very scary, isn't it? And additionally, just as Dr. Nurul pointed out, among the drivers in Malaysia, so they've noticed that, especially among these truck drivers and express bus drivers, I'm sure you would have heard many horror stories whereby bus drivers or buses are meeting an accident. Many people have lost their lives and a lot of casualties and all that. So they've done some screening program for these people, the truck drivers and express bus drivers, and to our surprise, of course, we noticed that some of the bus drivers, they've got OSAs. The prevalence is as high as about 6.6%. This is a long, study was done some time ago, but I bet to you right now, it is probably higher than that, right? Unfortunately, in our country, we don't have a law mandatoring them to undergo sleep study prior to obtaining these licenses. So yeah. So, hold on. Okay. Well, okay. What is positive airway treatment, right? So positive airway treatment is basically it's the gold standard, right? Okay. So why I call it gold standard, because this positive airway pressure or continuous positive airway pressure, it is invented in the 1980s by a professor from Australia, Colin Sullivan. So and this has been in the market or the modality of treatment since then. And believe it or not, this seems to be one of the most effective way of treating sleep apnea, right? Very effective indeed, yeah. But unfortunately, it is not very well tolerated due to many reasons, right? So if you notice that if a CPAP patient has, if an OSA patient has been prescribed with a CPAP device, please don't be surprised that their adherence is as low as 50 to 60%, right? So now, so there are some things that we have done to improve on this low adherence, right? So now, so what have they done? So first, they have tried a CPAP machine with humidification with the heated tubing system delivery. Now, what it means is that so you see, a CPAP machine will have a tube, and they have realized that if it's a plain tube, there is a chance that the patients after using it will have dry mouth and a dry nose and all that. So they've decided to humidify the tube and see whether it actually improves the adherence, but unfortunately did not. Then they came out with an APAP, right? Adjusted CPAP machine where the respiration is monitored and the minimum pressure is applied to sprint the upper airway, right? So the machine is getting more and more intelligent, right? So they're able to deliver a pressure which is just enough to open up the airway. So meaning that if it's an excessive pressure, so there are some side effects, like for example, they'll have aerophagia, meaning that the air, which instead of going into the lungs, it may go into your stomach, and the next day the patient will become a bit bloated and all that. So they're finding many ways how to improve the usage of CPAP for our OSA patients, right? But they also noticed that APAP or automated, auto-adjusted positive heparin has only small effects on compliance. And there's a special what do you call that, effect on the CPAP, meaning that they have a special function known as a EPR, expository pressure relief, or some other device, for example, like Philips and all that, they have what they call the term A-flex or C-flex. So this was investigated. So what it actually does is that this particular what do you call that, function in that CPAP allows the patient during an expiratory cycle to reduce the pressure of the machines at that point of time. Meaning that if we pick a CPAP machine at 10 centimeter water, for example, so because it is being a CPAP, CPAP means a continuous, so it doesn't have the what do you call that, a time where it reduces the pressure during a certain cycle of the breath. So we have two cycles. We have inspiratory and expiratory cycle. So during inspiratory cycle, when you inhale, the 10 centimeter water actually will be going in without any resistance, right? But during an expiratory cycle where you breathe against the 10 centimeter water, you may feel uncomfortable, right? So this expiratory pressure relief comes in handy because the machine detects your expiratory cycle and reduces the pressure from 10 centimeter water to perhaps 7 centimeter water, depending on how you set it, right? So that gives you a little bit of a relief while you're in the expiratory cycle. Yeah, I mean, that's in a simple term. Yeah, so this is the machine, Respiratory. So this machine had a combination of both. They have an APAP, plus they have a heated tube, and they got an EPR, right? And then they noticed that, okay, let's have everything in one machine. And they said that, oh, okay. So they could see a little bit of improvement in their compliance. Yeah. So now, how do you promote your CPAP adherence, right? Of course, the important is education. To be able to support, and of course behavioral intervention, right? So they have noticed that a 30-minute in a group social cognitive therapy versus a social interaction control group, there was no increase in adherence therapy. But they've noticed that there's an increase in adherence if her healthcare provider has an access to the patient's predicament. Meaning that if, let's say, a person is on, a physician has already diagnosed a patient of an OSA, and the physician has actually prescribed a CPAP machine, and we notice that after discharging the patient home, if someone follows this patient up by virtue of a nurse or respiratory therapist, they notice that the adherence is improving, right? Of course, it's quite natural, isn't it? You just don't discharge the patient home and say like, okay, TCA, PRN. No, we don't do that. So, but we still put them under our care. And of course, our TCA to our clinics are not very short intervals. There can be as long as about 4, 5, 6 months. And in between, there's nothing goes on. It's like a vacuum, right? So what they have decided is that by just don't let them be in the community just like that. So they employ nurses or respiratory therapists to go or to keep in touch, I mean, to get their numbers and keep in touch with them and constantly ask them how they're doing with the CPAP device. So they notice that the adherence is slightly increased, right? And another method is that they've used the index of non-adherence to PAP. It's actually a questionnaire, and this questionnaire they developed to see whether this patient actually will comply to the CPAP machine after obtaining it. Okay, now, usually how do you obtain a CPAP machine, right? You obtain a CPAP machine by virtue of coming to a hospital. You see a sleep physician or a respiratory or chest physician, and then you undergo some tests, and then they say that, okay, now you have an OSA, which could be a mild to moderate to severe, and then we ask the patient whether they want it to be treated. And then if they say that, yes, doctor, I'm more interested, I'm really interested, so they will undergo a trial, which is known as a CPAP trial. So this CPAP trial will be by a company, a vendor, and they go home with this device, and then a trial can go on up to about 7 to about 10 days, right? After 7 to 10 days, the patient will come back to see the physician, and a data will be recorded by the machine. So the machine nowadays, as I said, it's a very intelligent machine. The machine's able to generate a report of how the patient has been compliant using the machine for the last 7 to about 10 days. So in that report, you will look at some parameters. For example, the efficiency of the machine. They will look at the patient's adherence. They will look at the patient's AHI. The machine itself will be able to calculate the apnea-hypopnea index. The machine will tell us the leakage, which may or may not occur, right? And when it is. So these are the important parameters that we look at: the pressures, the humidification, the ramp. There are a few other parameters we look at. And after looking at that, you can know that if the patient has done well with the CPAP trial, and the patient felt better after using the machine, then you may want to decide to prescribe the machine for the patient or not, right? These machines can be very expensive, right? The machine can range between 4,000 to 6,000 to 7,000 in Malaysia. It's a CPAP machine of different brands. But what these people in 2014 has decided is that they came up with an algorithm or assessment score. They call it INAP, right? So index of non-adherence to PAP. And if they found out that the sensitivity is roughly about 87% and specificity by 63%, they realized that they will be able to decide which patient actually will be adhering to CPAP and which patient most likely may not. The reason why, because if you want to invest so much of money in a CPAP machine, and if the patient does not use it and keeps it aside, it's a shame, isn't it? It's going to be very expensive, and who's going to bear the cost? Now, once we apply, see, very few patients can afford to buy the CPAP machine on their own. Most of the time, they have to depend on some form of subsidy or some form of help from a third party. So we have to justify whether the patient actually will adhere, whether he needs this machine. Yeah. So those who fail, we have realized that since the adherence rate is a bit low, okay, those who fail to tolerate are unlikely to be referred for additional therapy. Meaning that if they fail to tolerate, right, unlike another person who is able to tolerate but dislikes the side effects, right? So it's all about perseverance, isn't it? Perseverance means that despite whatever, they still want to put it on before they go to bed, and they can go through the side effects. So these are the cohort of patients that we want to look at, right? So these are the patients who may, if despite having side effects, they still put it on, they want to preserve, you may consider this patient for other treatment options if they are keen, right? Now, okay, besides the CPAP therapy or positive airway therapy, so we also have the positional therapy. Sleeping in supine doubles the patient's AHI, meaning that if you sleep supine, the AHI, let's say, it may, they have an AHI about 15, which puts them in a moderate category, may just become severe 30 if they sleep in a supine, right? In a supine predominant OSA, risk of upper airway collapse at multiple level is higher as opposed to single level in a lateral position. So we understand that the level of obstruction is not one, it's not at a single area, but it's got multiple areas, right? I'm sure you're familiar with this graph. I mean, this cartoon. Dr. Nurul pointed out that, you know, how the obstruction takes place. There are multiple levels here, here, or even further down here, right? So the multiple levels of obstruction, right? So now, physical therapy significantly decreases the AHI, but the long-term compliance is also another issue. Newer improved devices are needed for those who cannot tolerate CPAP, or they can tolerate, sorry, those who can tolerate CPAP but cannot tolerate the side effects, right? So position therapy could be an option. So which kind of patient that you want to give a positional therapy? So those are the patients with supine predominant OSA. So how do we know it's a supine predominant OSA? This is by virtue of polysomnography, right? In polysomnography, you will look at the position of the patient when the most worst obstruction takes place. And if by looking at the polysomnography, you'll be able to identify which phenotype of patients will be successful with positional therapy, right? So this is an example of a positional device. It's known as a night shift. This is worn along the neck. What it does is that the moment the patient tilts to the supine, it starts buzzing, buzzing like that, and that will alert the patient, and the patient may just turn back to a lateral position. This is a picture which was shown earlier by Dr. Nurul, a positional therapy where you put, you wear around your chest area that doesn't allow you to turn. Yeah. Okay. Now we go to another option, which is nasal expiratory positive airway. So it is, unfortunately, it's not available in Malaysia. So the name, the commercial name is Provent. It's a single-use device and attached to the nostrils. It contains a mechanical valve which creates a high resistance during expiration, but not during inspiration. So the benefits are it decreases the AHI, it improves the oxygen saturation. Of course, it decreases the snoring. And of course, the side effects are they have dry mouth, nasal discomfort, and adherence is still an issue. This is how it looks like. Okay, you can see you just wear it on your nostrils. I hope I have a video. Can I play this video? Okay, I think because of time, I need to go on with my other slides. Okay, sorry. So it's in the YouTube. I'm sure you will be able to you know, go through it. Yeah. So the other device would be an OPT, oral pressure therapy device. It actually applies a gentle suction to the tongue, and the success of OPT is about 25 to 37%. Because it reduces the AHI, but AHI remains high due to positional apnea and collapse of the at the other levels besides the retro. Remember, I said earlier that the obstruction may not be at a single position. It could be in multiple positions. So by using an OPT, so it only decreases an obstruction at a single position, right? This is how it looks like. So you just wear it under, it just sits in the mouth like that and pushes the tongue down and causes a little bit of relief around this area there. But if the patient tend to have an obstruction elsewhere, it is not useful, right? So how about the oral appliances? So oral appliances prevents the airway collapse. It stabilizes the tongue, advances the mandible, and lifts up the soft palate. Sounds a little bit annoying, isn't it? Too many things are happening. But this actually will be done by the dentist, right? So what happens is that it is given for a patient with mild to moderate OSA. It reduces the AHI by 50%, not more than that. About 40% of the OSA patient has stopped using the oral appliances because of they have some side effects like hypersalivation and irritation to the gums and all that. Yeah. So the long term of OAs, they're not that great. The reason why, because the OA loses the effects on the AHI. So the reason behind this is actually the AHI of the patient actually doubles as you age. So OSA is a disease, if you really look at it, it's a progressive disease. It is a disease which may not be cured. Along the way, what will happen is that our body loses a lot of our tones, the muscle tones, and hence the OSA can get worse. So that's why at an efficiency of about 16.5 years after using an oral appliances, you notice that it is not as effective as how it worked at the first day they used it, because of the loss of tone and the aging process of our all our structures, right? So usually what we do is that we'll just have to repeat the polysomnography with the oral appliances and to see whether the patient still has an OSA or not. Yeah. Okay. So dry mouth, oropharyngeal crowding, these are some of the side effects of OAs. This is the OA that is available. But in Malaysia, I've asked a couple of dentists whether they'll be able to help us out. But not many people are actually, dentists are very keen on doing this, and it's quite expensive because it's custom made. Yeah. So this is another device where you have you put it in your tongue, and there's a slight suctioning of the tongue, which actually protrudes the tongue and allows a retropharyngeal space for you to breathe. This device is available actually. You can get it online, but the side effects are some abrasion to the tongue and all that. Looks a bit funny, but I've seen not many patients using it, but it's another option which is available. Yeah. So now, what are the surgeries that's available? So we have the tongue suspension, MMA. We have a UPPP. These are all basically done by our ENT colleagues, right? So this is our tongue suspensions where you actually have a device which you put it and then you screw it in your mandible, and then that actually pushes the tongue up and doesn't allow the tongue to fall back. This is tongue suspension. This is our MMA, mandibular maxillary, what do you call that? Advancement technique. So they do osteotomy which means that you notice over here, they'll break the jaw here and break the jaw here, and then they will put an implant here just to create a space. And while doing so, you'll be able to create a retropharyngeal space, right? This is by virtue of a UMMC, where they do a surgery to remove the uvula, if you notice, not to make the airway larger. And of course, this is by virtue of a laser-assisted uvuloplasty, right? Just to create more space, all right? And of course, this is tracheostomy. Basically, tracheostomy is the only modality which actually cures OSA, right? But of course, we don't do it routinely, right? Glossectomy is it's another surgery which to reduce the volume of the tongue, but glossectomy alone does not improve AHI, because as we know, it's a multi-level surgical approach is more important, right? And the last, I just want to highlight a little bit of hypoglossal nerve stimulation. So what they do is that we know where the hypoglossal nerve comes from. It comes from the olive and the pyramid at the back, near the medulla. So what it does is that, so we have a device here like a pacemaker, and we have a lid over here, which actually triggers the hypoglossal nerve, which in relation, it will contract the genioglossus muscles around the tongue area, and the tongue will get contracted, and hence some space is created here. You also notice that there is a sensory lid goes to the chest area over here, which actually senses the respiratory effort, sends the signals here, and we have an algorithm, and this impulse is created by the neurostimulator, and which goes and triggers the hypoglossal nerve, and actually makes the tongue retracts the tongue, right? This is something new, and I think it is being tried out, and it has got very good outcome. The side effects are usually tongue abrasion caused by tongue movements or discomfort due to stimulation. But some of us also notice that while using this device, they also have slightly increase in arousal index. However, the neurostimulator and all that can be adjusted is enough not to create any arousal. But we notice that it is not advisable for patients with a very high BMI, elevated BMI, a BMI more than 40. We notice that hypoglossal nerve stimulation has got no therapeutic effect. How about drugs? Very quickly, I want to say some of the drugs which is available, but nothing has been approved for treatment of OSA. For example, how to increase the ventilatory drive by giving theophylline. I'm sure all of us are aware of theophylline, which is used in patients for COPD, and some patients with asthma, COPD overlap. Acetazolamide is the diuretics which you always use for our eyes, for glaucoma. Also notice that's an increase in slight increase in ventilatory drive. Some cholinergic acetylcholine increase the upper airway. Antidepressants like some of the TCAs, but they notice that they can decrease the RAM actually to improve the OSA, but none of this actually improves works. Okay, all right. So with that, I thank you very much. I'm so sorry I had to rush through because I had some slides, but that would be end of my talk. So I give it back to the organizing committee. Thank you very much for your kind attention.
The outline of my presentation today, I will first start off with some introduction on the pathophysiology of cardiovascular diseases in patients with sleep-wheezing disorder, particularly obstructive sleep apnea. Then I will discuss the clinical evidence and treatment impact of obstructive sleep apnea on 4 major cardiovascular diseases, which are hypertension, coronary artery disease, heart failure, atrial fibrillation, and some other arrhythmia. So what happens to our cardiovascular system during sleep? Normal sleep provides us a time of low physiological stress, which is very advantageous to the cardiovascular system. During Hello? During non-rapid eye movement sleep, which is about 80% of total time during sleep, sympathetic activity decreases and parasympathetic activity increases. And this results in our BP, heart rate, ventilation, and metabolic rate to reduce, contributing to the relaxation of our cardiovascular system. So what happens during sleep? Sleep disorder, so what happens in OSA? Okay, OSA disrupts this low physiological stress state, which involves the 6 main mechanisms associated with sleep disordered breathing, is as illustrated in this slide, which are sleep reduction and fragmentation, intrathoracic pressure swings, hypoxemia reoxygenation response, sympathetic system activation, endothelial dysfunction, and increased thrombosis. In OSA particularly, the intrathoracic pressure changes causes stress on the normal cardiac structural function, like increase in left ventricular transmural pressure, the increase in LV afterload, increase in RV venous returns, and all this, okay, ultimately leads to the adverse left atrium and left ventricle cardiac remodeling. The cyclical hypoxemia reoxygenation response in sleep breathing disorder causes oxidative stress and increase in oxygen reactive species radicals, which then leads to cascade of inflammation activation and endothelial dysfunction. So all this mechanism, okay, will ultimately leads to the cardiovascular disease, particularly the 4 diseases that I already mentioned: hypertension, coronary artery disease, heart failure, and arrhythmia, especially atrial fibrillation. So let's move on to OSA and hypertension. The pathophysiology of hypertension in OSA is mainly due to the activation of sympathetic nervous system. There's an increase in catecholamine release. This leads to increase in muscle sympathetic activity and peripheral vasoconstriction. Another main mechanism is due to loss of nighttime dipping of blood pressure. As you can see, okay, in healthy patients, nighttime BP decreases, okay, about 10 to 20% of the daytime blood pressure. In OSA patients, okay, they follow this non-dipper, okay, and not only they follow the non-dipper pattern, okay, they experience recurrent nighttime surges, okay, due to the mechanism as I already mentioned to you before. So this causes rise in blood pressure in patients with OSA. So 2 major landmark epidemiological studies which shows that OSA is a cause of hypertension are the sleep heart health study, number 1, and the second one is the Wisconsin sleep cohort study. The sleep heart health study is a multi-site prospective cohort study implemented by the National Heart Lung Blood Institute in the USA to determine the cardiovascular consequences of sleep breathing disorder. The sleep health heart study started in 1998 and completed in 2011, includes about 6,441 participants aged 40 years and older. Today, there are about 150 publications regarding predictors and outcomes of sleep disorder on cardiovascular disease. So one of the earliest publication by Nito et al. As shown in this slide, the prevalence of hypertension increases with increasing AHI categories, okay? With 67% of severe OSA patients have hypertension. The odds ratio of developing hypertension from moderate to severe OSA is about 1.37, and this is even after adjusted to BMI, neck circumference, alcohol use, and smoking. The other landmark epidemiological study is the Wisconsin sleep cohort study. Okay, Wisconsin sleep cohort study is an ongoing longitudinal cohort study starting from 1989, and is still ongoing for 30 years now. It started off with a baseline sample of 1,500 Wisconsin state employees assessed at the 4-yearly interval. The initial focus of the study is to understand further on the prevalence of sleep breathing, but have now evolved to focus effect of sleep breathing disorder on cardiovascular and metabolic health, women's health and aging. And one of the initial publications showed there is a dose-response association between baseline sleep apnea and risk of hypertension. In this study, only 4% of the participants have stage 1 or worse hypertension at baseline. The odds ratio of developing hypertension for mild OSA is about 1.4, whereas in the severe OSA, the odds ratio of developing hypertension is about 2.89. Adjusting for the baseline hypertension status, non-modifiable risk factors, alcohol use, and cigarette use. Well, not only OSA is shown to be a cause of incident hypertension, OSA is also strongly associated with resistant hypertension. Well, in this study done by Pedrosa et al., published in the Hypertension Journal in 2011, the authors studied about 125 patients with resistant hypertension. All 125 patients underwent complete evaluation, which includes all plasma renin and aldo measurement, urine metanephrine, urine cortisol, thyroid function test, Doppler renal ultrasound, and also polysomnography. And what they found is that 64% of the patients with resistant hypertension have OSA, with 6.4% out of these patients have more than 2 causes of resistant hypertension. So OSA is a risk factor for resistant hypertension. In terms of the treatment impact of OSA with CPAP therapy on hypertension, Gottlieb et al. Conducted a randomized control trial of CPAP versus oxygen in 300 OSA patients. The patients is randomized to 3 arms, CPAP therapy, nocturnal oxygen therapy, and a control group receiving only lifestyle and sleep education. They discovered that 24 hours mean arterial blood pressure at 12 weeks was lower in the group receiving CPAP than in the control group and the nocturnal oxygen therapy group, by about 2.4 to 2.8 millimeters mercury lower. So in a meta-analysis of carried out by Fava et al. On the effect of CPAP on BP in OSA patients, which includes 29 randomized control trials, CPAP therapy reduces systolic blood pressure about 2.6 millimeters mercury. Well, although this reduction in BP is small compared to the effect of most antihypertensive medication available, the 1 to 2 millimeters mercury reduction in BP is actually associated with a reduction in the major adverse cardiovascular event. So, although small, okay, but it has very good effects on the prognostic of the patient. So, a meta-analysis carried out on the 6th randomized control trial evaluates the effect of CPAP in OSA patients with resistant hypertension. Okay. They found out that there is a greater BP reduction of 7 millimeters mercury with CPAP therapy in resistant hypertension. So in summary, OSA is strongly associated with hypertension, particularly resistant hypertension, and treatment with CPAP improves BP control. So moving on to OSA and coronary heart disease, okay, based on Wisconsin sleep cohort study, Shah et al. Studied the incidence of coronary heart disease in sleep-disordered breathing. This study includes about 1,200 participants with OSA, of which none of them have any coronary heart disease at baseline. So about 196 participants actually experienced their first cardiac event during follow-up, giving an incidence of 11 per 1,000 person years. After adjusting to BMI and smoking, the odds ratio of developing cardiac event is 2.4 in patients with severe OSA. So Punjabi et al. From the Sleep Heart Health Study group also showed that OSA severity is strongly associated with all-cause and cardiovascular disease-related mortality. As you can see from the Kaplan-Meier survival curve, the survival probability curve diverges, okay, every 2 years with increasing severity of OSA. This slide shows the outcome of patients with OSA after suffering from myocardial infarction and after percutaneous coronary intervention. Lee et al. Discovered that patients with severe OSA who suffered from MI have lower event-free survival post-MI, where the events studied are death, reinfarction, stroke, heart failure hospitalization, and unplanned vessel revascularization. The same author also discovered in another subsequent study that patients with OSA do far worse post-percutaneous coronary intervention with higher major adverse cardiovascular event, which is a composite of cardiac death, non-fatal MI or stroke, and unplanned revascularization. As you are all aware, acute coronary syndrome happens when there is a sudden acute plaque rupture in the coronary artery. Most of the time, there is an identifiable trigger. Why does the unstable plaque rupture to cause the acute coronary syndrome? Well, Newby et al. Identified triggers can be from physical or environmental or any mental stresses. The normal physiological response associated with awakening from sleep, actually, when there is a sudden surge of sympathetic nerve activity, can also actually trigger acute coronary syndrome. This actually gives rise to circadian rhythm pattern of acute coronary syndrome, when most ACS onset occurs at about 6 to 9 a.m. So, okay, that's where the most MI occur, in between during the early part of the morning. So, however, in OSA, with micro-awakening, recurrent nighttime cyclical oxidative stress have disrupted the circadian rhythm of ACS onset experienced by the general population. In a study done by myself with a collaboration between the cardiology and respiratory team in HUiTM, which we presented during both European Respiratory Society and ESC Cardiology Annual Meeting, we have found that there is a very high prevalence of OSA patients suffer from nighttime ACS, or what we call nocturnal ACS. Nocturnal ACS is defined as acute coronary syndrome that occurred during sleep at night, which awakens the patient. From our study, about 94% of patients suffered from nocturnal ACS have OSA. From our study as well, the predictors of nocturnal ACS are OSA, age, and neck circumference. So, in terms of the benefit of CPAP therapy to reduce cardiovascular events, 3 landmark randomized control trial has been done to determine the benefits. Okay, the CIRCAS trial, the first one, includes about 725 OSA patients with no prior coronary heart disease. And then the other 2 trials includes patients with established cardiovascular disease. With the SAFE trial, includes randomized over about 2,000 patients, OSA patients with prevalent cardiovascular disease into CPAP therapy versus visual care. All the trials, unfortunately, have failed to show any significant benefit in reducing cardiovascular events, partly explained by the poor adherence of participants to CPAP therapy. A sub-analysis of all the study where only patients who adhered to the CPAP therapy more than 4 hours per day were included in the analysis showed that there is actually a significant reduction of cardiovascular events. So in summary, there is a strong association between OSA and coronary heart disease, particularly nocturnal angina and nocturnal ACS. There is still limited evidence on the benefit of CPAP therapy in primary or secondary prevention of coronary heart disease event. So moving on to OSA and heart failure. The relationship between heart failure with sleep disordered breathing is a bit more complicated in which the symptoms and pathophysiology of heart failure and sleep disorder breathing are closely interrelated with each other. There are heart failure with reduced ejection fraction. There are heart failure with preserved ejection fraction, in which these two different types have different types of sleep breathing disorder which predominates, such as central sleep apnea rather than obstructive sleep apnea. And sometimes these two types of breathing disorders overlap with each other. Central sleep apnea is another type of sleep disorder breathing in which there is a loss of respiratory drive during sleep. OSA, on the other hand, is associated with reduction of airflow during sleep despite ongoing respiratory effort. This has important consequences, particularly in the management of heart failure with sleep breathing disorder. With regards to prevalence and impact of sleep disordered breathing and heart failure, Jaafar et al. Has summarized elegantly multiple epidemiological studies combining the prevalence and incidence of obstructive sleep apnea, central sleep apnea in patients with heart failure with reduced ejection fraction, with preserved ejection fraction, and those with acute decompensated heart failure. So about 53% of 1,607 patients with heart failure with reduced EF has moderate to severe sleep apnea, of whom 34% had central sleep apnea and 19% had obstructive sleep apnea. 47% out of 263 patients with heart failure with preserved EF had moderate to severe sleep apnea, of whom 23% have central sleep apnea and 24% have obstructive sleep apnea. Above all, heart failure patients with OSA have poorer prognosis compared to those without obstructive sleep apnea. So another one landmark trial in heart failure and obstructive sleep apnea, the CANPEP trial, showed that CPAP improved actually left ventricular ejection fraction, improved 6-minute walking time, they reduced the plasma noradrenaline level. However, there is no significant difference in heart failure endpoints such as hospitalization, quality of life, and transplant-free survival. Shown here is myself and Prof. Izwan presenting our paper to Dr. Douglas Bradley, the principal investigator of CANPEP trial during our ERS meeting in 2018. So, based on the post-hoc analysis of CANPEP trial, central sleep apnea in heart failure have poorer survival to those who did not have central sleep apnea. Despite the patient being on CPAP therapy during the trial, there are those who did not manage to have unsuppressed apnea-hypopnea index of less than 15, and this group have poorer prognosis. This suggests that other types of positive airway pressure is needed to manage sleep disordered breathing, particularly in heart failure. So just to go through some types of positive airway pressure therapy available, there are continuous positive airway pressure, automatic variable, and adaptive servo ventilation. Adaptive servo ventilation continuously adjusting inspiratory and expiratory pressures with variable on-demand backup rate. Multiple small randomized control trials have shown that adaptive servo ventilation improves heart failure dynamics and parameters. Well, however, in the SURF heart failure trial studies, the efficacy of adaptive servo ventilation in OSA with heart failure, these studies showed no difference in the primary endpoint, but a higher all-cause and cardiovascular mortality. The proposed hypothesis why this had happened are partly due to non-adherence the adaptive servo ventilation device algorithm, which induces hyperventilation and positive intrathoracic pressure. And another reason might be that the central sleep apnea is an adaptive mechanism to heart failure with reduced ejection fraction. So at the time being, adaptive servo ventilation is still not recommended to be used in patients with heart failure with reduced ejection fraction with sleep breathing disorder. Advent HF trial, which is ongoing with the principal investigator, the same Dr. Douglas Bradley, he is also studying the effect of adaptive servo ventilation in heart failure patients. And we are still awaiting the results of this study, which helps to see if there is still role of adaptive servo ventilation in heart failure patients. So talking about obstructive sleep apnea and atrial fibrillation, the disease mechanism in OSA causes acute electrophysiological changes and progressive cardiac remodeling in both atrium and ventricle. Majority of atrial fibrillation originates around the pulmonary vein, where isolation of pulmonary vein during AF ablation therapy prevents recurrent AF. However, in OSA patients with atrial fibrillation, they have other concomitant non-pulmonary vein trigger for the atrial fibrillation, as illustrated by this study. From the sleep heart health study, Mehra et al. Discovered that atrial fibrillation, non-sustained ventricular tachycardia, complex ventricular ectopy were more prevalent in patients with OSA. The odds ratio of developing atrial fibrillation in OSA patient is about 4.02 after adjusting to age, sex, BMI, and coronary heart disease. Not only OSA patients are at higher odds of developing atrial fibrillation, they also have higher AF recurrence even after successful ablation therapy based from meta-analysis. From meta-analysis of 8 trials, the use of CPAP have been shown to reduce the risk of atrial fibrillation in OSA up to 42%, with stronger benefits seen for younger, obese, and male patients. So, in summary, OSA is strongly associated with hypertension, particularly resistant hypertension, coronary artery disease, particularly nocturnal acute coronary syndrome or nocturnal angina, heart failure, and atrial fibrillation. So routine screening for symptoms of OSA is vital in patients with established cardiovascular disease. HUiTM et al. Have suggested, have recommended actually patients with resistant hypertension, pulmonary hypertension, patients with recurrent atrial fibrillation after cardioversion to straightly undergo diagnostic testing for sleep apnea. Okay, with that, I end my presentation.
So Dr. Haji Abdul Muttalif is a senior consultant respiratory physician and former director of the Respiratory Institute Kuala Lumpur and the head respiratory services in Malaysia before his retirement from Ministry of Health, and currently a professor of medicine in MAHSA University since 2017. He has presented numerous papers in both local and international meetings. He has also published more than 50 papers in peer-reviewed journals. He was also involved in numerous respiratory diseases guidelines in Malaysia, like like COPD, asthma, TB, and MDR-TB. Please welcome Professor Dato Dr. Haji Abdul Razak for his speech. Thank you.
Thank you very much, and Assalamualaikum to all of you. Can you see my slides?
Yes, yes, Prof.
Yeah, great. Thank you very much. So I'd like to thank you for inviting me for this topic this morning. I think cough is a very important topic. Why is it important? It's the most common cause of for reason to see someone in a GP clinic, in the primary care. I think the cough is one of the most common symptoms to see a doctor, because it happens to every one of us. You cough and I also cough. And why do we go and see a doctor? Because of frustration. Sometimes a cough can be unbearable. You go and see a doctor, and sometimes it can be irritable to your partner and also to yourself, and you get angry sometimes. And if the cough is very bad, you can't even sleep at night. And of course, whenever people cough nowadays, we always think of COVID-19. And don't forget cancer and TB. Okay, so at the moment anybody cough, you always run away because you worry about COVID-19. That's very, very important. Economically, it's also very important because we spend a lot of money on cough, a lot of money. People buy lots of medicine from the counter and over the counter for cough mixtures. They buy all kinds of cough mixtures from the counter, and even traditional medicine for cough, and it's really expensive. Look at this. They spend $4 billion US worldwide just for cough mixtures. So that's one of the most money-making thing for cough. This is per year. And UK, they spend almost about 1,000 million or 1 billion per year. They're just on cough medicine, and this is crazy. Because cough can be irritating, cough may be frightening, cough can be sometimes, like I say, stressful to all of us. This is a study done in 2015. It's very interesting. You can find that the European countries, quite a number of them got cough, and also down south Australia. I think those of you who know about asthma will know, because asthma is very common in European countries, especially in European countries and also in Australia. And so mostly the cough here is probably due to asthma. Whereas other countries like say India and say China and also Africa, there may be different causes. Maybe it's not due to asthma, maybe you must worry about TB or some occupational lung disease, whatever it is. So the rate ones are always due to asthma, most of the time. Why is cough? Cough, do you think is important? Actually, cough is very important. I always tell my students, cough is very important because it protects your lungs. We always cough out something from the lungs to bring out the organism, bring out the foreign body. So it's very, very important. So it protects the lung from any inhalation from noxious particles. And then again, when somebody has a lot of phlegm in your lungs, you also cough. If you do not cough, the phlegm do not come out. So you tend to sort of block the airway. You can't breathe very well. So how does the coughing, actually occurs to all of us? And there are three phases. They call the inspiratory phase, the compressive phase, and the expulsive phase. This is very interesting. Let me just go to one by one. The initiating phase is where something irritates your airway. Something enters the airway. It can be a foreign body, it can be a germ, can be a chemical, can be any irritant, and then they always affect the nerve and the brain area called solitary nucleus over there. So then they will stimulate you to inspire. So the first thing you actually, when somebody cough, they inspire first. So when you inspire, then the glottis opens. Diaphragm also contracts, and then your cage actually becomes big. Okay. And then the third phase is compression. So here is where your glottis close. Your glottis are closed, and then your lungs also try to compress to increase the pressure in your chest, and your diaphragm also will try to relax and then go further up. So all this pressure build up in your chest, and then you just cough it out. So this is the expulsive phase, where your glottis opens suddenly, and then you just have a loud noise to clear the airway. So it looks very simple, So when somebody coughs, it looks very simple, but the thing is, the phase is very interesting. They open, the air goes in, then they close, the pressure builds up, and then you just cough it out. Any foreign body or any germs or any phlegm, you just cough it out to the environment. That's the basic thing about this cough pathophysiology. What triggers a cough? Anything in the airway, okay? So the airway can be the first place where they trigger the cough. So something irritating airway can be acid, can be capsaicin, can be bradykinin, can be prostaglandin, can be any foreign body, okay? And then when it trigger, and then it goes to your brain. So the brain center is where they will actually trigger the cough automatically. And all these things is sent to the brain by the vagus nerve. So there can be a cough center in your throat, in your large airway, and also in your small airways. And these are all brought over there by the C fibers and the myotic fibers over there. And the cough center they call nucleus of tractus or solitaris in the medulla. So this whole thing looks simple, but the thing is, it's very complicated. So if you want to know why they cough, it can be anywhere. Okay? It can be anywhere they actually can cough. So how do they define cough? Because the thing is, the cough can be either acute cough less than 3 weeks, or subacute 3 to 8 weeks, and then chronic is more than 8 weeks. So today I'm going to talk more about chronic cough to you all. So it will only be more than 8 weeks. I'm going to talk only for adults, so not children. So we're talking only about adults and the chronic cough more than 8 weeks. So we'll forget about the acute cough and the succubate cough. Okay. So what are the causes of cough? This is very interesting again. The cough can be 3 things. It can be from the lung and the airways. So this can be the origin where the patient actually cough. So commonly asthma or bronchitis or bronchiectasis or drug cause, and all these things will cause cough from the lungs. Number 2 can be effusion. Any person can effusion in the pleural cavity. They can also irritate the cough center through the vagus nerve. They will tend to cough. And diaphragm, again, surprisingly, some people can have diaphragm irritation. They also tend to cough. So don't forget about diaphragm. And then lastly is that the mediastinum. Any tumor in the mediastinum, will irritate the cough because they compress the airway. Can be thymoma, can be neuroma, can be keratoma. They will just compress over there. And don't ever forget heart disease, okay? I always tell my students, heart failure patient will also tend to cough. When I was a young doctor, I saw a very nice case of what they call mitral stenosis with an enlarged left atrium. They call Orner syndrome. Enlarged left atrium compressing the vagus nerve, and the patient just came in to cough and cough and cough. So surprisingly, the cough can be from anywhere in the thoracic cavity. It can be from the lungs, can be from the heart, can be from the thymomas, and can be from the teratomas, can be from diaphragm, can be anything that irritates the coughing. This is the lungs and airways. But you can also get cough. We can also get cough in the head and neck. Don't forget the rhinitis and sinusitis. Anything outside the airway or the outside the lungs, in the nose, in the mouth, in the throat, can also cause cough. The most common is rhinitis and sinusitis and polyps. Okay, it's very, very important. And don't forget CNS. This is very interesting. I'll tell you the story later when I come to this topic again. Psychogenic cough is something we always don't think about. And tics are common in small children. Sometimes for the children, they become a habit to cough. The Gauss dilatory syndrome, again, is something very rare. I've seen in movies, one movie, nice movie, but not very common. I've never seen in real life, but it's a rare thing. They all are form of tics, that's all. I don't forget GERD, okay? So GERD, again, can be a common cause of cough for some of us. So interestingly, cough can be inside the lung by many things, can be in the upper, can be in the brain, can also be in the lower in the GIT. Types of cough, again, is very, very important. It can be explosive kind of cough, wheezy kind of cough in asthma and COPD. There can be productive cough like in bronchitis, pneumonia, and they can have dry cough in patients with AIDS and GERD and lung fibrosis. And again, barking cough is more acute. I want to go through. I just want to share one case with you all. I was in IPR. Before I left IPR, I saw this case, very interesting case, and a very sad case. I tell you why it's a sad case. This patient, 6 years old Indian man. He was a retired government servant. He was an engineer before, and he went to UK to see his daughter in UK. And he was having cough and cough and cough since 2015. This is long ago, I saw him in 2018. That's 3 years, after he was coughing. He was also breath and exertion over the last few years. Then many people saw him, thought it's infection, they give antibiotics, they thought a cough, they give cough mixtures, and then they even thought COPD, they gave bronchodilators. Nothing made him get better. He got no signs of heart failure at all, no pain, no autopnea at all. He is very sad because he can't play golf. Retired people, most of the time, they spend time in the golf, You couldn't play golf at all because it's breathlessness, Then lucky one doctor referred to IPR. But a bit too late, after 3 years, a bit too late. And this is the X-ray. For those who can see the X-ray, they definitely got a bit of cardiomegaly over there. You can see the peripheral opacity and opacity lower zone. Same thing left side, opacity periphery. This is what they call the reverse bed swing. The bed swing you see in the heart failure. This is what they call the reverse bed swing. You see opacity more on the periphery and the bases. Okay. And then we did CT scan for the guy. And then CT scan shows fibrosis in the periphery. And then also got a bit of bronchitis due to traction bronchitis, and they feel it is due to IPF. Okay. So very sad. Okay. So we diagnose this patient IPF after 3 years of symptoms and delay in diagnosis. So this is very important in primary care. If somebody cough and cough and cough and cough, please, think of something that is not so good. Okay, not so normal. Okay. So we did a lung function test for him. For those who don't know lung function test, let me just make it brief for you. We'll only look at these traits: FVC, FEV1, FEV1, FVC ratio. And all the time, my students, if there's anybody give you a spirometry, the first thing you look for is the ratio here. FEV1, FVC ratio. The ratio is more than 70%. In more than 70%, it can either be normal or restrictive lung disease. So it is 85. Its forced vital capacity is 2.0, FE1 is 2.05. It's only is less than almost half compared to normal. Normal should be 4 liters. It can only blow 2.05. Forced vital capacity, normal should be 5. It can only blow 2.4. So this is 50%, then this is 50%. The ratio becomes 85. So this is obstructive lung disease. So very sad. We missed this patient diagnosis for 3 years of coughing. It's very sad. So let me go and talk about chronic cough again. Okay, these are the most common cause of chronic cough. I'll try to go through some of them. I wouldn't go through all, but let me just go through some of them. But don't forget the bottom one, please. Okay, and then I forgot to add one more thing. COVID. COVID is more of acute. Okay, it's not chronic. But nowadays, people who got post-COVID syndrome, they come with a lot of bad cough, can last for years and for long, forever they can cough because of the lung fibrosis. So I should add COVID over there. I'm not saying COVID, but post-COVID syndrome. That's the other cause of chronic cough for these people. First thing I'll talk about is asthma. One of the most common cause of cough is asthma. Asthma is very interesting. They can present in 3 ways. They can present a classical asthma, where the airway is inflamed and then the airway is narrowed and the airway is hyper responsive. The airway is sensitive. The second type of asthma is the cough variant asthma. This is what people say. 20% will just come and cough, just like me. I cough. When I talk a lot, I cough. Okay, because I got mild asthma. Okay, so whenever I talk a lot, whenever I say something, or when I give lectures too much, my airway is hyper responsive. I tend to cough. The third type is the cough in eosinophilic bronchitis, almost like asthma because also eosinophils, but they don't have bronchoconstriction or they don't have hyperasthma. They only got high eosinophils. So asthma can be present by 3 ways, but today because of cough, just think of cough when asthma. 20% will just come with cough, So if you see any patient coming to the clinic with cough, 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 X-ray is normal, patient looks good, no other symptoms, I think of asthma when they're young, please. Very, very important. Okay. So again, this is what I want to say. And most of the time, we do a spirometry for airway constriction. We do a spirometry for reversibility. We check the sputum of eosinophils. We check the blood for eosinophils. We can do a bronchial propagation test, not done in Malaysia, most places, except for 1 or 2. And then I always tell my students, the most important thing for asthma is history. Okay. They tell a classical history, a family history, childhood history of asthma, father got asthma, father or mother got eczema, rhinitis. All these things will give you a clue that patient got asthma. So asthma diagnosis, if you ask me, most of the time is by clinical diagnosis. Rarely you may need all these things. All these things are needed only if you're not so sure what's wrong with the patient and just to help you get diagnosis. Okay. So first thing, anyone chronic cough is my thing to you all is asthma. Second thing is, of course, don't forget smoking. Don't forget tobacco smoking. Okay, yeah? Most of the time, smokers will get cough because of COPD. Very important. Yeah? They get cough because of COPD. So you must ask them about smoking history and ask them how much you smoke and how long you smoke, everything. But this is very interesting. This is very interesting. There's a thing called pro-tussive effect. This is a new study. They found that people who smoke with no COPD, when they smoke, the tobacco actually decreases smoking. Very interesting. So don't go and smoke. Okay, if somebody cough in the clinic, don't ask him to smoke. Okay. They found that early people, when they got no COPD, when they smoke, the smoking content sometimes can suppress the cough. So they call it a pro-tussive. It does not cause the patient to cough a lot. Okay. So, but then again, very important, you must tell them this is only temporary. The moment the lungs are damaged, they go to COPD, the cough is there permanently. Okay. That's number 2 for chronic cough. ACE inhibitors, again, last time we used a lot of ACE inhibitors for hypertension. Now we got a lot of new drugs, it's very much better. About 20% people got ACE, when you take ACE for hypertension, will get a cough, phendoprine, lisinopril, all this thing. They tend to cough. And again, they found this very commonly, I'm sorry, they found it more commonly among Chinese in Malaysia. Okay. So you see any Chinese patients, we are coming cough, cough, cough. Don't forget to ask, are they taking medicine for ACE inhibitors now, for the hypertensions. It can occur within a few hours. You can occur within a few hours taking the medicine, or even up to 6 months later. The mechanism is all these things. I will go to later in a graphic form. So if you think the patient got cough because of ACE inhibitors, change them to the ARBs. They may improve. But remember, it may take up to a month for them to improve, you know. It doesn't mean when they stop the ACE, they will become better immediately. Yeah? Sometimes some of this cough will take a bit longer to get better. So tell the patient, be patient. We think it's due to ACE inhibitors. I mean, stop the ACE for you and give you something else for your hypertension. But it may take about a month or up to 3 months for the cough to go off. So don't worry. Okay, that's what I can tell the patients. What's the mechanism? This is a mechanism. Huh? This is the ACE inhibitor. We have got bradykinin in the body. The bradykinin will be converted to inactive metabolite. So when the patient takes ACE inhibitor for the hypertension, it blocks this ACE. When the ACE is blocked, the bradykinin cannot be converted to inactive metabolites. There will be lots of bradykinin in the body. So when there's a lot of bradykinin in the body, that's where they stimulate your cough. They get angioedema, they vasodilate, then they get all the degradation over there, and the patient tend to cough because of all these things builds up because this thing cannot be broken by the ACE inhibitor. And that's a basic mechanism for ACE inhibitor causing a cough. Okay. This is again something we already talked about, the GERD. Okay. GERD is something again very common in many of us because, as you know, yesterday's news I saw, the obesity in Malaysia is getting more and more and more. Okay. So there's a headline I saw. And it's very sad. Okay, one of the most common cause of GERD is obesity. Yeah? You got a big tummy, you eat a lot, and then you eat at night, and then you eat rubbish sometimes. I'm sorry to say this to y'all. Malaysian eat a lot of rubbish. Okay, yeah? And I'm always one person who very worried about all these mama shop. Okay, I always tell them we should close the mama shop by 12 or by 10 if I'm very happy. Yeah, by 10 we're very happy. The more the shops are open, the more people will eat, and they got more obesity in the country. You know? It's very sad. And the rate for the GERD is very interesting. Some studies say 0%, some studies go up to 100%. Okay, yeah? Can cause chronic cough. Very interesting. So the cough can either be originated from the larynx or can be further down there. Okay, yeah? So anything down here where the acid just goes up can also cause a cough. Sometimes they say it may not be the acid, it can just be a gas, you know. It can just be the gas from the stomach going up there can also cause you to cough. Not only the acid itself. Huh? And sometimes the gas can be produced here in the pharynx itself, not in the stomach. So the origin of the GERD can be somewhere here or can even be on top. And they can stimulate the vagus nerve, and that's why the patient tend to cough. How do they cough? They only they clear the throat because they feel irritating in the throat, they clear the throat. And the cough normally occurs at night because when they're going to sleep. When they sleep, the acid just goes up, and then that's why they tend to cough. And of course, when they're eating, they get this cough, you get irritation. And how the symptoms are, again, they feel there's a heartburn, there's a water barrage, they get a sour taste in the throat, and then they feel something regurgitating. And every morning, because the acid has gone to your airway and upper airway, you feel your throat is a bit hoarse and voice early morning. These are symptoms they get in the early morning. Don't forget drugs, okay? Some drugs can also cause GERD, like theophylline. Then the beta agonist, okay, for your asthma. And don't forget their painkiller, the NSAID. Taking too much vitamin C can also cause you to have GERD, and calcium channel blocker can also cause GERD. So these are things you must ask them in the history. Are you taking this, and this, or what for you to get a GERD for these patients? And of course, food again, please. You take chocolate a lot at night, or you take a lot of coffee before you go to sleep, or peppermint alcohol, and then you're really fat or fatty kind of food, I'm sorry. They can all trigger you to get GERD at night, please, and they tend to cough. So all these things must come in history taking to find out the cause of the chronic cough for these patients. So we will do two main things, or three for the matter. 24-hour pH monitoring, look at the pH at the different levels of the esophagus, upper part, the middle part, lower part, see whether it's acidic going up the upper esophagus or not. This is something very interesting. They put at the hydrogen esophageal manometry. It's more accurate than this, I believe. And of course, OJDA look for other causes of gastritis. Okay. They find that a lot of patients with GERD will also have some gastritis, also gastric ulcer. So if gastric ulcer, they also have more chance to get GERD sometimes. So you treat the gastric ulcer, and then that thing can disappear. So again, treatment for GERD is PPI. And you must give them for long, up to 2 months. And again, lots of studies say that sometimes some people benefit by giving the patient treatment for PPI. Some do not benefit. It's very sad. Very sad. Okay, it's very controversial, but it was a try. Okay, it was a try. Some people also believe that the esophagus can be a lot of motility problem in these patients. They give prokinetic like domperidone and metoclopramide, like Maxolon. And again, they try to remove all the other drugs and causing the GERD. And baclofen, is a muscle relaxant. Again, for the motility problem, it may help the patient a bit, okay? Yeah? But then again, nothing is good for GERD. You can try one by one, that's all. The number 5 cause is this is something new. They call upper airway cough syndrome, something new. The old name is called post-nasal drip syndrome. These are called UACS. So again, can be many causes for upper airway cause. It can be sinusitis, can be early rhinitis, can be post-infectious sinusitis, can be drug-induced rhinitis, can be due to environment again. Something triggers a sinus, you tend to cough. Many causes. So the post-nasal drip is the old name. A new name is called the UX, upper airway cough syndrome. But then again, let me just go to post-nasal drip syndrome. So how do they present? They always feel that something goes from your nose to your throat. And then again, you're trying to clear your throat. And then the nasal discharge always be there. And then always people who got this post-nasal drip, they cannot sleep flat. They cannot sleep flat looking at the ceiling. The moment they sleep flat looking at the ceiling, that's why the thing will just go and drip to the throat, and then they wake up suddenly because they feel like choking. So always tell them sleep at the side, left or right. Very, very important. I already mentioned to you all these causes. Okay. And then again, always make sure that you exclude infection. The most common cause of this thing can be infection. Infection causes secretion to your post-nasal area. It goes on to your throat, you tend to cough. Treatment again is nasal steroid for at least for 2 months. Sometimes antihistamines are very good. And then again, the Muttalif singular is also very good because it can affect the upper airway. And sometimes it's very, very bad ENT people, they go and do a saline lavage for the patient. Okay. If all these things do not work, all you refer to a ENT guy do a laryngoscope. Laryngoscope is very important to look for other causes of this patient's cough in the upper airway. Very, very important. So once the lung specialist don't know what to do with the patient, make sure you refer to ENT, look for the upper part of the airway. Number 6, chronic cough and other disease. This again is something very important. We always forget these things, okay? The moment the patient got something chronic going on, we already think of something physical kind of cough. So your lungs are already distorted because of damaged lung. When lungs are damaged, when they're distorted, that's why they tend to have a cough, which can be a prolonged kind of cough. Okay, very, very important. Like lung cancer, patient with cystic fibrosis, patient with bronchitis, patient with bronchitis, they all are damaged lung, and they all will cause a mechanical kind of effect, and they all will have a cough. Don't ever forget young ladies when they come with cough and cough and cough, you must think of SLE, you must think of rheumatoid arthritis, you must think of scleroderma, you think of sarcoidosis. They all can cause either effusion, lung nodules, or lung fibrosis. And all these things will definitely tend to get a cause. Look at this, up to 90%. Of 90% patients who got some ILDs will cough. ILDs is structural damage to your lung. The lungs already got fibrosis, so they actually will tend to cough. Okay. I'm sorry, you can't see this sarcogenic cough. This sarcogenic cough, again, you must exclude everything else. Then we can say it is due to sarcogenic, commonly seen in the adults, and then mostly due to the emotional kind of disorders. Okay, I'm gonna tell you a story. I was in Terengganu for many years, and I saw one police officer in Dungun. So I went to Dungun for my monthly visit, and then they referred the case to me. And this police inspector brings all the convicts to the court to present to the judge. The moment he enters the court, you tend to cough. You tend to cough, So this actually is the cough induced by emotional stress. Okay. Whenever we see the judge, he tend to cough, he gets stressed so much. Okay. So treatment for him is don't go to court anymore. Finish. Abhijita. So don't forget that some kind of stress and emotional kind of disturbances can also cause cough. They got no sputums. They can sleep well at night. Then you can get any commixture, they all are useless. Okay. Yeah? So again, history is very important. Okay. Tick, I already told you just now. Tick again is common in small children. So it's very, very important to exclude other causes of tick these patients. I wouldn't go through. Number 8 is the argument. There are about 50% people come with chronic cough, don't know what's wrong with them. So you have to find out again and do the test again and do the test again, do a test again After doing a few tests from 46%, they say that only 10% will have something unexplained cough. Okay, so 10% people in your clinic will have cough and cough and cough. We don't know what's the cause. So it's just too bad. Okay. So pitfall in diagnosis again, recognize again. This is very recognized again. Very, very important. We must remember that there's a cause for cough and can be multifactorial, not only one cause. That's very important. Again, I mentioned GERD and then the upper airway kind of irritation burst cough and then the phlegm production. Don't forget the GERD, okay, please, and don't forget the asthma. Okay, these are common causes for cough, which is chronic, okay. And pitfalls in management again, people always treat them for short terms. Whenever you see asthma, upper airway kind of cough, you must treat them up to 1 month or even up to 2 months. GERD may have to go up to 6 months. So you give them for 1 month treatment, may not be enough. So you must treat them for a long period, very, very important. And again, you must look for all the other things. Look for the food, the lifestyle, and then the medication patient taking. And all these things come into play. They may have other disease, they can also cause cough, hypertension, and then the GERD, gastritis, everything, and then rhinitis, can all cause cough, okay. And don't forget your psychogenic cough, okay, very, very important. And like I say, sometimes the cough cannot be explained 10% of people. So do not ignore the change in character. So sometimes they can cough, 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 but the moment the character changes, you must think of cancer or some other infection like TB or what, very important. I got many patients with COPD, they cough, 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 but trouble is people do not do the X-ray and they're having TB or lung cancer. Please, this is very important. You find the cough is changing in character, just get exam for the patient, okay? If they are smokers, you must worry about cancer. If they are smokers and diabetes, you must worry about TB, very important. I wouldn't go to this thing. So this again by the European guideline, the ARS guideline came in very interesting thing 2020. They came in a guideline for chronic cough. History is very important. Once you get a proper history about all this patient drug and everything, then you do a chest X-ray. Very important, just do a chest X-ray for the patient, okay? They will tell you whether normal X-ray or not. Once it's normal, then you think of asthma, you think of COPD, you think of upper airway kind of cough and everything. And you can do your busulfan and everything. And then everything else come back and negative, your patient is still coughing, then you go and look something further. You go and do the check for TB, check for eosinophil, do a laryngoscope for the patient, do a chest CT scan if you are very not so sure, and even sometimes bronchoscope. Okay, these are done in a special center. So this is very important, please. This is very, very important. Any person come with a chronic cough is a structural damage. You must identify. And the best thing is get a chest X-ray. In a primary care, getting X-ray is the most important thing. I always tell my patients, any person got chronic cough, the first thing you must do is do a chest X-ray. Commixture is the people always get commixture in the pharmacy. So I never get commixture. You can ask any of my doctors in IPR. I don't give commixtures at all. Okay, please. You must find out why they cough. Cough is a symptom which can be bad. You must know why they cough. Okay, I'm going to go to. I just want to show you something. I want to show you this thing. Red flags. So you got any patient got chronic cough, the moment they got hemoptysis, change in voice, dysphagia, and a patient got fever, weight loss, and then X-ray abnormal, please, please, please think of something very bad. So this is what they call red flags. Okay, so when we see all these things in a patient, refer to a specialist, please. Get the X-ray and refer to a specialist. Management of cough, again, difficult to manage them. Okay, difficult because we don't know what's the cause of cough. Sometimes we don't know what's the cause of the cough, which is important to give them a treatment. And then again, different treatment varies from person to person. Different modalities again. So some people say sequential. We don't know what's the cause of cough. So give them one thing first. We think of asthma, give them ICS for 2 months or 3 months. And after that, you cannot improve. Give them, we think is good, give them PPI. 2 or 3 months, cannot improve. Then some people, they find there's no other cause of cough and then no cancer, nothing, everything. They even give low dose morphine or cough suppression drug, there's a morphine content, may be helpful. If everything else fails, they also send the patient for some counseling or cough control therapy. Okay, this is something basic in management. So again, mentioned by the European Respiratory Society, the ERJ in 2020, what I mentioned is the same. Okay, so they go by sequential therapy for the patient. Okay. So my last slide for you all is that history is very important, please. Take a good history, examine the patient, And please do a chest X-ray, please. Okay, do a chest X-ray. You think asthma or bronchitis about, do a spirometry of the patients. Like the moment the patient red flags, hemoptysis, weight loss, fever, think of something very bad, refer to a specialist. Okay, do the basic, please. This is very, very important. Do the basic thing in primary care, and then once they are stuck, refer to a specialist. If you're worried again, please refer to a secondary sort of a clinic or tertiary clinic to look for further investigation. Thank you very much.
About definition of community-acquired pneumonia, epidemiology of this disease, particularly in Malaysia. What are the microbiology and how does understanding of this microbiology give us approach of antibiotics in dealing with community-acquired pneumonia? What are how we diagnose community-acquired pneumonia, as well as differential diagnosis. Before that, the common presentation of community-acquired pneumonia. Once we make the diagnosis, what are the treatment as well as the follow-up plan. So community-acquired pneumonia refer to acute infection of the lung that occur in community outside the hospital. In contrast, nosocomial hospital cover both hospital-acquired pneumonia and ventilator associated pneumonia, whereby in these two infections it occur in hospital setting. Hospital-acquired pneumonia refer to the onset of pneumonia after 48 hours of hospitalization. VAP refer to pneumonia after 48 hours of intubation. The chest X-ray over your right hand side illustrate how pneumonia looks on the chest X-ray. So pneumonia on the chest X-ray will present as consolidation. One of the typical findings of pneumonia is a bronchogram. You can appreciate over here, you can see airway lining. The reason for this, all the airway spaces is filled with fluid during pneumonia, during the inflammation. So the only things that still filled with air in the lung is the airways, giving you a bronchogram appearance. So pneumonia is the second leading cause of death in Malaysia. This is census published in year 2020, second after ischemic heart disease. So pneumonia is one of the leading cause of death in Malaysia. But if you look at the female population in year 2019, pneumonia is the leading cause of death. In fact, a year before, in 2018, still pneumonia is the leading cause of death in our female patient. So pneumonia is very important, one of the leading cause of death in our local population. If we look at the hospital admission for pneumonia, we can see numbers of hospitalization for pneumonia is common among the extreme age, either age less than 5 or for those age more than 50 years old. Both for community-acquired pneumonia and hospital-acquired pneumonia. In addition to age, the other causes for, or the other risk factor for community-acquired pneumonia is the underlying comorbidities. We can see from this graph, this blue color. So the risk of cardiovascular disease is common among those aged more than 50 years and above. So in addition to age, underlying comorbidities also play a role for a risk factor for pneumonia. The leading cause will be cardiovascular disease, followed by lung disease presented by the purple color. Other common risk factors are immunodeficiency, renal disease, and chronic liver disease. For this reason, I think for the next slide, Prof Pang will talk about the role of vaccination in those who are elderly, as well those who already have underlying comorbidities. By having pneumococcal and influenza vaccination, it can reduce the risk of severe form of pneumonia. I already changed the slide. So the common organism in our local population is call it gram-positive followed by gram-negative. There's also atypical organism. Bear in mind, especially in our local community, incidence of Mycobacterium tuberculosis is also high. So commonest is gram-negative positive, followed by gram-negative, atypical, as well as Mycobacterium tuberculosis. If we look at other population in Asian country, we can see similar findings. Among the common community-acquired pneumonia, the commonest will be Streptococcus pneumonia. So again, pneumococcal vaccine is very important, that because Streptococcus pneumonia is the commonest organism that can cause community-acquired pneumonia. How about the difference between Asian population and the European population? Again, for community-acquired pneumonia, you can see the commonest organism that can cause community-acquired pneumonia is Streptococcus pneumonia. So very important that we advocate pneumococcal vaccine for our patient. Okay, let's compare between those treated in community and those treated in hospital. Again, the commonest organism will be Streptococcus pneumonia. Followed by atypical organism. Now, we know that Streptococcus pneumonia is the commonest organism that can cause community-acquired pneumonia. But in terms of death, 50% of death in pneumonia is caused by Streptococcus pneumonia. So 50%. Half of your patient who died from pneumonia, the organism is caused by Streptococcus pneumonia. Similar findings, either in young patient or elderly patient. So both Streptococcus pneumonia is the leading cause of death in adult patient, in elderly patient as well as young patient. If we add the other organism, example your respiratory virus, Haemophilus influenza, if we combine the other organism, still the percentage is far less compared to Streptococcus pneumonia. So very important, we advocate our patient to have pneumococcal vaccine. In terms of presentation, can divide the symptom into two: pulmonary symptom as well as systemic symptoms. The common plural pulmonary symptom will be cough. Either can be productive or non-productive, shortness of breath, as well as pruritic chest pain. The systemic symptom will be fever, of course, chills, fatigue, malaise, and anorexia. In the current COVID-19 pandemic, sometimes it's quite difficult to differentiate whether the patient having bacterial pneumonia or COVID-19 infection. In terms of clinical findings, so pneumonia will present as consolidation. So we do the clinical examination. The typical findings for consolidation will be increase in breath sound as well as tactile parameters, and the chest expansion will be reduced on the affected side. Pneumonia can also present as part of the complication, for example, pleural effusion, lung collapse. So the findings for pleural effusion that differentiate between consolidation and pleural effusion, the tactile parameters and the tactile parameters and vocal resonance will be reduced in pleural effusion, contrast to consolidation, whereby in clinical examination there will be increase in the tactile parameters and vocal resonance. So how we diagnose community-acquired pneumonia? So we have to have combination of few things. Number one, there is a pleural symptom, respiratory symptom of acute lower respiratory illness. Example, cough, as well as other lower respiratory symptom. When you do the clinical examination, there is a focal chest sign, as well as one other systemic features I mentioned to you before this. For example, sweating, fever, shivers, ache, and body pain. Temperature more than 38 Celsius. And there is no other explanation of the illness. How about, is it necessary to do chest X-ray to diagnose community acquired pneumonia? Because I mentioned in my initial slide, one of the features of pneumonia is there is radiographic changes. So in BTS guideline 2009 mentioned it's not necessary to perform chest X-ray in patients suspected to have community acquired pneumonia unless there is doubt in the diagnosis, patient did not respond to the initial treatment, as well that patient is having high risk of lung cancer. In our community, in our setting, the risk of tuberculosis. So if straightforward patient, it does not require chest X-ray. But if we doubt our diagnosis, we are dealing with something else, for example, lung cancer, TB, or patient does not respond, by all means, we have to do the chest X-ray. This study is performed by Dr. Irfan and his team in Penang Hospital, looking at the misdiagnosis of community acquired pneumonia who presented to Penang General Hospital. So the commonest misdiagnosis will be upper respiratory tract infection, followed by heart failure, infective exacerbation of chronic lung disease, ACS, surprisingly, scabies. Scabies also can be diagnosed as pneumonia. Okay, it's diagnosed as pneumonia. So when you see your patient who presented with a sign and symptom of maybe community acquired pneumonia, please do rule out this other differential diagnosis. Next, once we confirm the diagnosis, we want to know the severity of the infection. So it's based on three things: clinical judgment, comorbidities, and social circumstances. Based on these three things, then we can decide whether to treat the pneumonia in community or to refer patient to hospital. So in terms of clinical assessment, the score that we use to assess severity of community acquired pneumonia will be CRB 65. Right? So in hospital, use CURB 65, CURB 65, but in community setting, in your clinic kesihatan or your private clinic, you don't have the facility to do the renal perform. So you use CRB 65. What does CRB 65 score measure? It measures whether patient have confusion. C, R, refer to respiratory rate more than 30s. B, blood pressure systolic more less than 90 or diastolic less than 60. Again, age more than 65. Right? One of each criteria will give 1 point for the patient. So patient will have score 0 to 4, and the score of CRB 65 correlates to the mortality in 30 days. When the patient have score of 0, the mortality in next 30 days will be 1.2%. In contrast, if patient have score 3 or 4, the mortality is up to 30%. So based on this risk of mortality in the next 30 days, then we can decide whether to treat patient in community or refer to hospital. Those who have score of 0, you can treat in community. Those who have score 1 or more, then you want to refer this patient to hospital. Other assessment that does not cover in the CRB 65 score is your oxygen saturation. So now almost everybody have oxygen saturation machine at home, the simple pulse oximeter. We can use that to assess severity of pneumonia. Those who have saturation more than 95, more likely the oxygen level, the oxygen concentration in the blood is within the normal range. If the saturation is less than 90 to 94, patient have mild hypoxemia, and those who have less than 90 are more likely to have respiratory failure. So respiratory failure is defined when the oxygen level is less than 60 millimeter mercury. In this case, you want to refer patient straight away to hospital. The study done in major looking at the predictor of mortality in community acquired pneumonia assessment. So they look at age, oxygen saturation, blood urea, any comorbidities, and community score of more than 3. So in this multivariate analysis, the only things that are significant after the multivariate analysis is the oxygen saturation. So oxygen saturation is the strongest predictor of mortality in community-acquired pneumonia. So in addition to oxygen saturation, is there anything else that we should do for patient that we diagnose for as community-acquired pneumonia? So based on this PTS guideline, for simple pneumonia, score of 0, there's no requirement to do a routine culture, either respiratory culture, blood culture, or urine test. But in outbreak of certain disease, for example, in UK they have Legionella or Mycoplasma. In that particular duration, you want to do the additional test. Looking at our current pandemic, maybe you want to do a COVID-19 screening. Bear in mind, this guideline is done by British Thoracic Guideline, Thoracic Society. So for our local population, you might consider to do a sputum for TB. If you, based on the history and examination, that patient more likely to have Mycobacterium tuberculosis. Now, once we establish the diagnosis and the severity is low, then we can decide patient to have community treatment. So in terms of antibiotic choice, there is our own national guideline for antibiotic published in 2019. So again, before we decide the antibiotic, we have to establish the severity of the infection. Once the severity is 0, then we can treat patient in community, and the treatment of choice will be amoxicillin, 500 mg given 3 times per day for duration 5 to 7 days. Why we want to give amoxicillin? Because majority of the organism is gram positive and should be covered by the penicillin group. Alternatively, we can give Augmentin, combination amoxicillin and carbapenem acid 3 times. Still, duration is almost the same, 5 to 7 days. Alternative will be doxycycline for those who have allergy to penicillin group. Interestingly, in ATS and IDSA guideline, year 2019, it differentiates between those who have comorbidities and those without comorbidities. Those who have no comorbidities, you can consider amoxi and doxycycline or macrolides, almost similar to our local guideline. But for those who have comorbidities, you want to give Augmentin, amoxicillin and carbapenem acid, as well as macrolides to have a broader coverage. BTS 2009, quite an old guideline, almost similar to Malaysian guideline. So those who have CURB score of 0 can give amoxicillin, and those alternative will be doxycycline for those who have allergy to penicillin, doxycycline or clarithromycin. In addition to antibiotics, you should advise patients to have good rest, drink plenty of fluid, and do not smoke. Paracetamol or simple analgesia should be used to treat pruritic chest pain, and do advise your patient to have pulse oximeter to monitor the oxygen level. Please review your patient after 48 hours of your treatment or earlier if clinically indicated. Those during the follow-up, you should reassess the disease severity using the score that I just mentioned to you just now, CRB 65. And those who fail to improve after 48 hours of treatment, this group of patients should be referred to hospital or or you should perform a chest X-ray. How about chest X-ray follow-up? So BTS guideline 2009 mentioned in those who have satisfactory clinical recovery, you don't have to do repeat chest X-ray. But in those who have persistent symptom and physical sign, or those who belong to high risk of malignancy, those who are smoker, age more than 50 years old, and significant history of smoking, in this two group of patients, you must do a repeat chest X-ray. Based on the chest X-ray findings, then you can decide whether patient require further investigation. Then you can refer to us. then we decide whether the patient have to undergo CT scan or bronchoscopy. This is an article looking at why we miss lung cancer and the reason for that. So one of the reasons that we tend to miss lung cancer on the chest X-ray because we do not interpret or assess the chest X-ray systematically. I think Dr. Rokia mentioned to you just now when we Dr. Bushra explained in yesterday's session. In order to interpret the chest X-ray systematically, we should have a system. So we should compare site to site from one zone to another zone. The commonest area that we miss chest X-ray finding will be at the epices at the hila, behind the pericardium, as well as near the diaphragm. So do look at your chest X-ray systematically and pay more attention on the epices, hila, behind the pericardium, as well above your diaphragm. Okay, that is my final slide. I hope I explained the management of chronic acquired pneumonia in a simple manner. So I invite any question from the audience.
All right. Yeah, thank you very much for the introduction. So I shall just continue. Yeah. So the topic given to me is on the pneumococcal as well as the influenza vaccines. And then I'd like to focus on who and when. And this is the content of my talk. I'm just going to go through the rationale of vaccination and outline what are the available vaccines to prevent respiratory infection at the moment, and what is our target, and when is the right time to institute the vaccination. So the following are the rationale of vaccination. So when we actually implement vaccination, as you know, usually is given to a wide range of individuals. So the objective is the main objective is to prevent individual from being infected with organisms, particularly those that normally result in high mortality or morbidities, like what we have seen recently, the COVID-19, and the recent past, the pandemic influenza, and also to a certain extent to prevent the transmission of this organism in the community. If you can successfully prevent the infection, you can also prevent the transmission in the community. So it's not just meant for the individual, but also for the community. So in order to achieve maximum impact, the vaccine or the organism targeted must be of those that normally cause a widespread infection. And besides, the vaccines recommended must be able to achieve sufficient efficacy in the high-risk individuals, particularly also those who are maybe to a certain extent immunocompromised, and they must not have a high rate of unacceptable adverse reactions. Obviously, if you are giving something to prevent a disease, the something should not be worse than the infection that we are trying to prevent. So at the moment, for respiratory infection, there are quite a few vaccines available. As you know, the COVID-19, the influenza, of course, this has been implemented for many years. The pneumococcal infection, pertussis, diphtheria, this is mainly for children, but now I think for pertussis, in GO guideline, it has also been advocated for adult patients with a COPD to prevent the risk of COPD exacerbation. And then, of course, BCG vaccination, although by and large, it is not very effective in preventing tuberculosis, but it is being implemented in countries with still having the high risk of TB endemic. And this is actually mainly to prevent the dissemination of TB as well as TB meningitis in children. But our focus for this lecture will be on influenza vaccine as well as the pneumococcal vaccine. So first on the influenza, we know that it is caused by a virus. It is spread via the droplets and possibly the aerosols as well. It is highly infectious because anything that's spread through droplets and aerosol, I think tend to carry high transmission rate. But of course, it's also subject to the variants, whether they could attach themselves to the receptor in the airway. And we know that influenza also carries a high mortality as well as result in significant morbidities. So how bad is influenza before the COVID-19 pandemic? We can say that influenza affects about 10% of the world population, and which amounted to about 500 million people. So this figure is really staggering. 250 to 500 people die every year because of influenza-related deaths. And these deaths mainly occur in those who are above 65 years of age. And 3 to 5 million people actually had the more severe form of influenza. And between 20 to 30% of children worldwide catch the influenza every year, and they are the main source of transmission. Okay, we know influenza is a virus. It belongs to the Myxoviridae family. So this is an encapsulated single-stranded RNA virus. So just like the COVID-19, it is an RNA virus. We know that any virus which have a single-stranded RNA, they tend to mutate much more frequently compared to those with DNA. The core nucleoproteins are used to distinguish the three important subtypes of influenza viruses, A, B, and C. And then for influenza A, the heme agglutinin or the HA and the neuraminidase is used to differentiate the various subtypes. So that's why when you read influenza A, the strain is always read as H1N1, H3N2, for instance. So H stands for the heme agglutinin, N is the neuraminidase. So what is the role of heme agglutinin plate in the process of infection? Heme agglutinin serve to bind to the respiratory epithelial cells, and this will allow the virus to enter the cell, resulting in cellular infection. So if there is some mutation happening to the heme agglutinin, they may become more infectious or less infectious. On the other hand, the neuraminidase clasps the bond that holds a new replicated virions to the cell surface. This will allow the continuous spread of the virus. the virus need this enzyme to break up the bonds that hold the newly replicated virions inside the cell. So allow the virus to escape into the surrounding and hence allow the continuous spreading of the viral infection. Without this, the virus might be, the virion might be trapped inside the cell. As alluded earlier, influenza A is genetically labile, meaning that its mutation rate is very high. It is 300 times more than other microbes. And we also learned that there's something called antigenic drift and another condition called antigenic shift. So drift is just a small change, whereas shift is actually a major change. And drift usually is due to point mutation in the viral RNA. On the other hand, antigenic shift usually is due to reassortment, often occur during co-infection of two viruses in a single host. For instance, what you can see on the cartoon on your right, yeah, the swine flu virus and the human flu is affecting the host at the same time. And because these two viruses are present in the same host, they can actually bind together and result in a reassortment of the virus. And as a result of this, the virus produced is unrecognizable by the immune system, and it has the potential of causing the widespread transmission, as well as very sudden emergence of very severe disease. And this is as what we saw in 2009. And also, some of these viruses are capable of transmission between mammals, meaning that the swine flu may actually cause human infection. And same thing with the bird flu, it can actually cross species, causing human infection. So antigenic drift also have certain impact on the human. It alters the virulence of the virus. Well, if the virulence is reduced, it is probably not causing so much of a severe disease. But if the virulence increase as a result of this mutation or the antigenic drift, it may suddenly cause a more severe form of human infection. The other significance of the antigenic drift is that it may result in the virus being unable to be recognized by the human immunity. We know that either we acquired many immunity either through natural infection or vaccination. But because of the constant changing of the virus serotype, it will result in evasion of the human immunity. And as a result, the annual influenza vaccination is required. So WHO has outlined the high-risk groups, and this group are the main targets for the annual influenza vaccination. They include pregnant women at any stage of pregnancy, children with immature immune system, those between 6 months to 5 years, and elderly individuals who are 65 and above, individual with any chronic medical conditions, as well as healthcare workers. I think here the healthcare worker is not so much that they are going to get more severe disease, but they are more likely to get influenza infection because of the nature of the work environment. They are more likely to acquire the infection, and the risk is not just to the healthcare workers themselves, but also to their family, and more importantly, to the patients they are taking care. And we know that many of the patients that we are taking care are immunocompromised or having chronic medical conditions. Hence, it is very important to vaccinate ourselves to protect people surrounding us. What about the safety of influenza vaccine? As I alluded earlier, the vaccine that we are going to give should be efficacious enough, and yet at the same time carry acceptable side effects profile, because we do not want to give something that is more harmful than the disease itself. And for influenza vaccine, because of the many years experience and in influenza vaccine production, we know that so far the vaccine produced, they are very safe, right? And then scientific study have shown that they also have a very good favorable safety profile. The common side effects will include the local side effects like soreness, weakness, or swollen arm. Some patients may experience fever. I think majority of them do not have fever, and occasionally patient may experience the mild influenza-like symptoms such as muscle aches, headache, and fatigue. I think sometimes in the media, the Guillain-Barré syndrome has been highlighted, but we know that while we can't deny that actually in rare occasion it could actually cause this, but the number of cases is extremely low. It's only 1 to 2 additional GPS per million flu vaccine doses administered. And we have to realize that if the individuals catch a flu, there is also a risk for them developing Guillain-Barré syndrome. And the risk through natural infection is so much higher. So who are the target population for influenza vaccine? I would say that almost everyone in the community who are at risk of influenza, because you know that it affects a wide spectrum of people in the community. Some are at higher risk of mortality and morbidity, as outlined previously. So in order to spread, in order to prevent the spread in the community, ideally, everyone should be vaccinated. Just like the strategy that we have embraced for COVID-19. But however, the cost and willingness of the patient may be an issue. So in resource-limited countries like ours, perhaps we should target the high-risk individuals and also people who are taking care of the high-risk individuals. And this is actually the recommendation made by the Malaysian Society of Infectious Diseases and Chemotherapy. And this is the latest edition, the 3rd edition, I think published about 2 years ago, essentially outlining who should be the target groups. So when is the right time to give influenza vaccine? We know that in our country, there's no seasonality, and hence anytime is the right time. Okay, but if you wanted to actually aim at actually the latest batch of influenza vaccine, so you can refer to this table to see when is the latest batch of vaccine is made available. For Northern Hemisphere, it is available somewhere in September or October, and for the Southern strain is between February and March. All right, so in the temperate countries, typically It is given during autumn to prepare for the winter spike. Tropical country like us, I think anytime opportunity should be capitalized when the patient come to the clinic visit or are hospitalized. Because the vaccine take about 2 weeks to develop sufficient immunity. So anyone traveling overseas or performing pilgrimage, they should take the vaccine at least 2 weeks before the trip. And of course, during pandemic, we have to take additional vaccine because the seasonal flu vaccine may not be adequate to protect us for the pandemic flu. So I've completed flu talk on the flu. So let's turn to the pneumococcal vaccination. And we know that Streptococcus pneumonia is one of the commonest culprits causing community-acquired pneumonia. And this is a gram-positive diplococci and encapsulated by polysaccharide capsule. And this also determines the virulence of the bacteria, as well as defining what is a serotype. And we also know that polysaccharide is a target for vaccine development. At the moment, we know that there are more than 90 serotypes circulating in the community, but not all of them are important because the more virulent serotypes are usually the targets of the vaccine development. The reservoir, this bacteria normally stay in our nasopharynx. Children is the most important carrier. After birth, within a few months, most of the children nasopharynx will be colonized by strep pneumonia, and this will continue until they reach adolescent, and the colonization will reduce as they get older. So people who have young children at home, the risk of strep pneumonia is much higher. That is also the reason why children are one of the main targets of pneumococcal vaccination, apart from the older adults. Partly because we want to achieve the so-called herd immunity. Transmission occurs through direct contact or the wire format. There are also reports saying that it could transmit via the respiratory droplets. Incubation usually is quite short, within 1 to 3 days. So what are the major clinical forms of pneumococcal disease? I think we can divide them into invasive disease and non-invasive disease. Non-invasive means they just infect the mucosa and not going into the bloodstream. Invasive disease means that they have bacteremia, or when they affect the meninges. This is known as an invasive pneumococcal disease. Pneumonia could be either classified as non-invasive or invasive, depending on whether there is any bacteremia present at the same time. Strep pneumonia, if you look at the inpatient bacteria isolate, strep pneumonia perhaps is not the commonest bacteria, but if you look at organism that is isolated for people who are not who are diagnosed with CAP but are not admitted, I think the proportion of strep pneumonia is much higher. It is reported that this contributes to about 3.1 to 5.5% of all the cases of a CAP in Malaysia. Why young children and adults are our main targets? You can see from this graph and also the explanation behind immunosenescence. That means aging of the immune system is the main contribution. So we know that adults are at increased risk of pneumococcal disease as our age increases. And you can see the cutoff is actually not happening at 65, actually much younger. So our risk will substantially increase after the age of 40. And I think it's quite significant once we reach the age of 50. So that's the reason why the pneumococcal vaccine is like PCV 50 is approved for adults who are above 50 years old who did not have any significant illness. But of course, if they have any sickness, then you may have to vaccinate them even earlier than the age of 50. And also, why adults are much more likely to suffer from this disease is because as we get older, we also more likely to acquire other chronic medical illness. And this will also increase our risk as well as morbidities. Here you can see that older adults, it's not only that they are more likely to get pneumonia, they are also more likely to get bacteremia. And as a result, most of the admission for pneumonia secondary to strep pneumonia is contributed by the older adults. And then you can see the burden of pneumonia in Malaysia. You can see two peaks over there, but you are seeing a much bigger peak in the older adults. And then what about certain medical conditions? You can see that if we have chronic lung diseases, the risk of invasive pneumococcal disease increases 7 times. Okay, it's not 70%, it's 7 times. And similarly, if you have other chronic conditions such as heart disease, diabetes, the risk will increase substantially. And if you are talking about just the non-bacteremic pneumococcal pneumonia, the risk also is higher, and in fact, it's much higher. Not only coexisting medical condition influence our risk, but also the presence of the number of underlying medical condition. From this graph, you can see that the more comorbidities that we have, the more likely we are going to get to acquire CAP due to strep pneumonia. So what are the types of pneumococcal vaccines available at the moment? We know that polysaccharide has been there since the 80s. This is known as PPV23, or is marketed under the brand of Pneumovax 23. Why 23? 23 means is 23 valence, cover 23 serotypes. So this is by far cover the widest spectrum of strep pneumonia serotypes. The more so-called the later pneumococcal vaccines developed were conjugated with the protein. So why protein is so important in the pneumococcal vaccine development? Because it was found that if you are just targeting the polysaccharide, the immunity developed is not long-lasting. Usually, the effects may be diminished after 2 to 3 years. So in order to improve on the long-term immunity, this vaccine is being conjugated with the protein. Okay, hopefully it will stimulate the T cell and result in the long-lasting immunity in the memory cell. So for PCV, I think we have we have PCV13, PCV10, and PCV7. I think PCV7 is being made obsolete. So what we are using at the moment is a PCV13 for adults and PCV10 for children. And these are the serotypes included in the different vaccines. Okay, you can see the overlap and the gap, what are not being included in PCV13 versus PPV23. So the big question is who should be given pneumococcal vaccine? Here we have to refer back to the Malaysian Infectious Disease and Chemotherapy Society recommendation. This is the latest revision, and inside they actually mentioned that for anyone aged 18 to 59 with pre-existing medical condition, they should receive 1 dose of PPSV23, and all adults 60 years and above, ideally they should receive 2 doses, PCV13 followed by PPSV23 in that sequence. If they can't afford, maybe we can consider 1 dose of PPSV23. And adults with a significant immune compromising condition, I think the pneumococcal vaccination should be intensified. So the preferred sequence is always PCV followed by PPSV23. So you can see here, those with a significant immune compromising condition, and you want to roll out the pneumococcal vaccination fast, then what you can do is you inject the PCV13 after more than 8 weeks, followed by the PPSV23, and we repeat the same dose of PPSV23 after more than 5 years. And once we reach 60 years, or at least with a gap of 5 years, we can give another dose of PPSV23. All in all, we should only give maybe a maximum of 4 doses, not more than 4 doses. I think a lot of people say that the vaccine should be given every 5 years. I think this is probably a myth rather than actually based on recommendation. And of course, if individuals have been given PPSV23, we may have to wait for a year to give the PCV13, and then wait for another 1 year for PPSV23. And again, after the age of 60, we have to give a booster dose of PPSV23. And anyone going for pilgrimage, it is recommended that they receive 1 dose of PPSV23. Of course, I think you can also give PCV13.
Now we'll move on to the next segment of the day, which is the last segment for this 2 days course. There's a question and answer. Or there's no questions and answer. How about from the floor? Okay. Which is a large symposium sponsored by GlaxoSmithKline in collaboration with our partners, GSK. And I would like to invite Dr. Muhammad Amin, who is a consultant respiratory physician of HUiTM, to give his talk on keeping asthma under control in primary care.
Yeah, Assalamualaikum warahmatullahi wabarakatuh. I'm going to present the final session, the last symposium sponsored by GSK. So the aim of this presentation, hopefully we as primary care doctors, or you as primary care doctors, you can optimize your asthma care in your clinics. So when we talk about asthma, asthma is chronic airway inflammation. So the keyword is airway inflammation. So how we diagnose asthma? So as the first presenter in yesterday, she mentioned about we need two things. We need symptoms, and that is variable expiratory airflow limitation. So the common asthma symptom will be wheezing, cough, shortness of breath, and chest tightness. So in terms of variable expiratory airflow limitation, we can confirm that by using a spirometry, compare pre and post bronchodilator FEV1. In your clinic kesihatan, you don't have this spirometry machine, you can use alternative tests, which include your peak flow meter. Either you do pre and post peak flow meter volume, or you can use asthma diary, looking at the symptom and the diurnal and variable PEF reading over 2 weeks. In patients who have typical symptom, but yet we cannot show variable expiratory airflow limitation either from spirometry or peak flow, you can refer this patient to do a Muttalif challenge test. In our country, Sedang is the only center who offer this service. So asthma, aim of asthma treatment is to address two things, symptom and exacerbation. Unfortunately, there are also other things that we most of the time neglect, which is the lung function, airway inflammation, airway remodeling, and bronchial hyperreactivity. So in this study, Wafi, can we change the slide to the PDF slide, because this PowerPoint slide does not show the correct slide. Can I have the PDF form? Sorry, with some technical error. PDF ada? PDF file. Sorry for the technical glitch. That is the problem when you prepare your slide and use Windows to present your slide. Any questions so far? Based on the few slides. PDF. Boleh kita go through more. That is that project on the screen. Tak boleh tekan tak? Siapa tu stop ni kan? Okay. Those in Zoom, can you see my slide? Okay. So this study tried to look at the airway remodeling based on the subepithelial layer thickness. The more the more the thick the indicate the more severe airway inflammation. So we divide patient into 3 categories: severe asthma, moderate asthma, and mild asthma. Based on asthma severity score, we measure symptom, bronchodilator use, as well as the PF variability. So based on these 3 parameters, and we can divide patient to mild, moderate, and severe asthma. in comparison to healthy subject. So we can see across the asthma severity, regardless whether it's mild, moderate, or severe, the airway remodeling is present. So the subbacterial layer thickness is much greater compared to healthy subject. In fact, those who have severe asthma, the thickness is more compared to those who have moderate and mild asthma. So airway remodeling does occur across the asthma severity. And how does we assess asthma control? So why is it important to have good asthma control? Because we want to address two things. We want to improve the symptom and reduce the risk of future exacerbation. So what do we mean by good asthma control? Patient have no daytime symptom as well as no nocturnal symptom. Patient able to perform his or her regular activities, and patient rarely use the reliever medication. And why is it important to prevent future risk? Because asthma exacerbation can cause death. It can cause persistent airflow limitation. As the asthma getting worse, we going to give more medication to patient, and this of course can lead to harmful side effects. So how do we measure asthma control objectively? So one of the questionnaire that we can use to objectively assess asthma control is asthma control test, or ACT in short, which measure 5 domains. Number 1 is activity limitation, shortness of breath. Number 3, awakening due to asthma symptom. 4, reliever medication. Last is global judgment of asthma. How do we interpret the ACT score? Those who score more than 20, we define this patient as well controlled. With score between 16 to 19, not well controlled, and those score less than 15 have poor asthma control. And the minimum clinical important difference, or MCID, is 3 points. So in this study, we look at 8,000 asthma patients in Europe. So when we do the objective assessment, only 20% of these 8,000 patients have objectively assessed well-controlled asthma. So the rest, 80% does not have good asthma control, either partially controlled or uncontrolled asthma. But if we ask patients how they describe their asthma control, more than 80%, the opposite, consider the asthma control is well. In fact, almost half, 44%, experience asthma exacerbation that require oral corticosteroid. We call it severe exacerbation. And 75% of them regard the asthma is not well, it's not serious. So there is a mismatch between the perceived asthma control and the objective asthma control. How about in our local population? So this study by Thompson et al. Published in year 2013. So in our local setting, there is about 400 patients by Prof. Roslina is recruited in this study. So more than 50%, 56% in asthma patient in Malaysia describe their asthma control is well in the past 4 weeks. Again, when we measure objectively the asthma control using the GINA score, only 6% of them have controlled asthma. The remaining 94% either partially controlled or uncontrolled. Again, similar finding. There is mismatch of patient symptom, reported symptom, and the objective assessment of asthma control. Why is it important? Because mismatch of the symptom either under-perceive or over-perceive asthma symptom will lead to over or under treatment of asthma. So about quarter of the patient who are stable under-perceive their asthma control. So they think the asthma control is well, but when we do the objective assessment, the asthma is not well controlled. So in this group of patients, they tend to underuse the reliever treatment. and there is delay in initiation of the medication because they think the asthma is well controlled, so no need to take any regular medication. If we allow these things to happen, this will lead to progressive poorer asthma control. In other hand, some of asthma patients, they think the asthma is not well controlled, but we do the objective assessment, the asthma is well controlled. So in this group of patients, there is overuse of reliever medication, and unfortunately, this also will lead to overuse of inhaled corticosteroid or long-acting beta agonist. Both medication have potential side effect. So underestimate or overestimate symptom can lead to harm. If we compare, now looks at the asthma guideline published by GINA in year 2020 versus the latest one in 2021. So if you look at your left-hand side, this is the previous guideline. So you notice in the latest guideline, there is 2 separate tracks for reliever. So in previous guideline, there's no separate track for reliever. It's too small to appreciate the writing. So let us focus on the latest guideline in year 2021. So in latest guideline, so we have 2 separate tracks. The above track, we call it controller and the preferred reliever. And the second track is controller and the alternative reliever. So the difference between the first track and the second track is the type of reliever. For the reliever, for the first track will be the use of combination ICS formoterol at low dose for reliever. For the second track, the reliever is similar to the previous guideline, which is short-acting beta agonist. The next question, when we initiate the asthma treatment for our patient, which medication should we start? So to answer that question is based on the severity of the symptom. For those who have less symptom, mean that the symptom is less than 4 to 5 days in a week. In this group of patients, you may consider to give step 1 or step 2 treatment. If patient having more severe symptom, most of the day causing awakening at night, and more than nocturnal symptom more than once a week, then this group of patient we want to give step 3 treatment. Those who have daily symptom, then you want to consider step 4. So I mentioned to you just now, in the GINA guideline 2020-2021, we have 2 separate tracks. What are the key consideration to choose whether track 1 or track 2? So it's not that straightforward. So we have to know the efficacy of giving fixed dose preventer medication, and if we consider to give PRN, ICS, formoterol combination, which one is better? What is the safety profile? If we use, if you decided to give regular preventer, does patient going to adhere to the regime? Particle size, now we have extra fine particle. Does it translate to a better control in terms of asthma patient? Cost and availability, I think that this is the most important question, especially when you practicing in the clinic kesihatan. So to give all your patient formoterol ICS combination as preventer and reliever medication, it's not a widely available option. You have quota, you have limit to give this patient the desired inhaler. So again, we have to go back to the basic of asthma disease. I mentioned to you in my early slide, asthma is a airway inflammation. So a patient having symptom, we should address the airway inflammation. We just focus on the symptom, just giving a bronchodilator, we just open up the airways. We did not address the underlying key pathogenesis of asthma, which is airway inflammation. If we address the airway inflammation by giving inhaled corticosteroid, we can improve bronchial hyperresponsiveness. We can prevent airway remodeling. Of course, we can reduce the airway inflammation. This, in long run, will reduce exacerbation and better long-term outcome. So the next question, how we decide to give a proactive regular dosing, PRT in short therapy, or should we give a flexible dosing therapy? A single reliever, a single inhaler for maintenance and reliever. On the top of that, we have various inhaler types, which is the best for our patient. I think Dr. Arif already presented this slide yesterday, looking at the asthma death in UK population. So about 38% of patients who died in the previous year, they received less than 4 inhalers containing ICS. So by right, they should receive at least 12 if you use every month. So ICS canister prescribed in the year should be 12 canister. But those who die from asthma, 38% of them receive less than 4 canister containing ICS. The reason for that, they are over reliance on short-acting and long-acting beta agonists. In fact, 15% of them receive LABA therapy alone. So we should never give long-acting beta agonist alone in asthma treatment. If you want to give LABA, you should in combination with inhaled corticosteroid. Sadly, 43% of them do not have any annual review in GP in a prior year before they died. So they don't have any regular follow-up. I think with the COVID pandemic, most of our patients did not have any regular follow-up. And the regular follow-up will be in the emergency department. We don't do regular follow-up in the emergency department. Okay, make sure that our patient do have regular follow-up. Why is it important to start inhaled corticosteroid early? I mentioned to you just now, asthma is airway inflammation. We want to address the airway inflammation. This will translate to better outcome in terms of symptom and exacerbation. We can prevent airway remodeling because we know some patient after having asthma for a long period of time, we do the pre and post bronchodilator, there's no reversibility anymore. The reason for that, because the airway is already remodeled because of the persistent inflammation. As well, we want to reduce airway hyperresponsiveness. This will translate to a better improvement in lung function test. If we focus on your inhaled corticosteroid just for symptoms and FEV1, I think we are not doing any justice for our patient. So if we give inhaled corticosteroid to our patient, the first things that patient notice, there is no nighttime symptom, followed by improvement of FEV1 and morning peak flow. Later on, patient does not require short-acting beta agonist, and the airway is become less responsive. So the airway is almost normal later on. Now, this study, we compare 3 arms, the preventer. So we have asthma preventer, 3 types of asthma preventer. The first is regular budesonide. Second arm is daily Zafilucas. And the third arm is intermittent use of budesonide whenever patient having symptom. So from this table, we can see in terms of giving regular inhaled corticosteroid will translate to better improvement of FEV1 compared to the other 2 arms. The other positive outcome, giving daily ICS, you can see improvement in ACT score, which is indicate a good asthma control, as well as numbers of symptom-free days. So giving a regular inhaled corticosteroid to our patient does lead to better asthma control and spirometry findings. Now, in this study, what they try to assess is two things. Number one is the FEV1. Second is airway hyperresponsiveness measured by PD20. What does PD20 refer to? PD20 is the dose of methacholine required to cause reduction of FEV1 by 20%. The higher the dose of methacholine required to cause bronchoconstriction, significant bronchoconstriction, reduction of 20%, the less airway in terms of responsiveness. The higher the number of PD20, show that the airway is less responsive. So in this study, they follow up patient over a period of 12 months. After the 12 months, they stop the medication. So what they found out, by giving a regular inhaled corticosteroid, you can see marked improvement of FEV1. However, after 3 months, it plateaued throughout the study period. So FEV1, after 3 months, it will plateau. But if you continue to give inhaled corticosteroid, you can see the dose of methacholine required to cause significant bronchoconstriction increases. What does it show? There is it prevent airway remodeling. So the airway become less responsive. Require more methacholine to cause significant bronchoconstriction. But once we stop the inhaled corticosteroid, the FEV1 will reduce, and the dose of methacholine required to cause significant bronchoconstriction is also reduces. So the airway hyperresponsiveness reoccur again. So when we give ICS to our patient, does not only we try to improve the symptom, the spirometry, we also promote airway to prevent airway remodeling. This is a Sigma study. So in this Sigma study, try to look at what medication is best for mild asthma. So there is 3 arms. The first arm will be budesonide formoterol PRN. So single inhaler for maintenance and reliever in form of budesonide formoterol. The second arm, we're going to give regular budesonide inhaler. On the top of that, whenever patient having symptoms, they will take terbutaline as needed. And the third arm, just Sabah alone. And then follow up this patient for a period of 52 weeks. So when you look at the symptom defined as weak without any symptom, we can see by giving this number is odd ratio. So by giving budesonide on regular basis compared to budesonide formoterol combination PRN, we have better weeks without any symptom. The odd ratio is less than 1, so it's significant. In terms of annual rate of severe exacerbation, by giving regular budesonide and budesonide formoterol MAT therapy, there's no significant difference in terms of exacerbation. What does it conclude? So by giving regular ICS, we have better symptom compared to PRN, budesonide formoterol. In terms of exacerbation, is no different between these 2 arms. Now, let's look at the airway inflammation. So we can measure airway inflammation using exhaled nitric oxide or FeNO. Second is sputum eosinophil. So you can see there's 2 arms. The gray color represent regular ICS, the blue color represent intermittent ICS. Both graphs show that by giving regular ICS, we can reduce exhaled nitric oxide, less airway inflammation, as well as sputum eosinophil. So giving regular ICS reduce airway inflammation. Giving regular ICS containing controller also reduce asthma-related hospitalization and mortality. So this is a finished study over a long period of time between 1981 till 2003. Yeah. What does this graph show? The blue color show population of asthmatic patient in population. So how many asthma patient in that country? The gray color show drug cost per patient. The red color show asthma death. The orange color show numbers of hospitalization due to asthma. So we can see, although numbers of asthma patient increases, the numbers of asthma death and hospitalization remain low. In fact, inversely. So we have increased number of asthma patient, but is the numbers of asthma death and hospitalization reduces. The reason for that, there is high use of inhaled corticosteroid. In 1986, 1/3 of the patient, of asthmatic patient, on inhaled corticosteroid. In fact, by the year 2001, almost all patients, 85% of patients on inhaled corticosteroid. So giving inhaled corticosteroid save life. So very important in your clinic setting, make sure your patient should be on inhaled corticosteroid, at least low dose. In fact, in the same study, it showed that by the year 1995, there is more inhaled corticosteroid prescribed to patient compared to reliever. So this is a ratio between inhaled corticosteroid against beta agonist. Ratio more than 1 show that we are giving more inhaled corticosteroid compared to short-acting beta agonist. So we should give more inhaled corticosteroid compared to short-acting beta agonist. Okay, next question is proactive regular dosing, giving regular ICS with long-acting beta agonist in moderate asthma. So in the last few slides, I show about mild asthma. How about in moderate asthma? So giving regular inhaled corticosteroid persistently, we can achieve asthma control in majority of our patients. 4 out of 5 patients, if you give regular inhaled corticosteroid, we can achieve good asthma control. This is a goal study. In fact, so in this study, there are 2 types of preventer. The first preventer is fluticasone alone, ICS alone. The second preventer is salmeterol fluticasone, combination of ICS plus long-acting beta agonist. It's given in 2 separate formulation. The first arm is low dose, the second arm is moderate dose. So giving inhaled corticosteroid in combination with LABA inhaler proven to reduce exacerbation far more better compared to giving inhaled corticosteroid alone. Both are true in low dose or moderate dose of ICS. So in severe patient, we should consider to give long-acting beta agonist in combination with inhaled corticosteroid. Okay, now we look at again similar findings. 2 arms are going to compare inhaled corticosteroid alone, the first preventer. The second preventer, we going to give inhaled corticosteroid in combination with long-acting beta agonist. So over this 52 weeks study period, we can see better asthma control in patient receiving combination of inhaled corticosteroid with long-acting beta agonist. In severe asthma, you should consider to give ICS LABA combination. Okay. So well control is defined whether patient have total control and partial control. So if we give regular inhaled corticosteroid, we can achieve up to 75% patient who have good asthma control. So good asthma control is not impossible. It's possible by giving a good asthma medication, which is inhaled corticosteroid plus LABA combination on regular basis. In contrast, if you use MAHSA therapy based on patient symptom alone for ICS LABA inhaler, your total control and partial control is much less, about 50%. In contrast, if you give regular LABA ICS, you can achieve good control in 75%. In MAHSA approach, we only achieve as good asthma control in 50%. About 45% of patients remain uncontrolled. So why? Because by giving MAHSA therapy alone, you can see significant numbers of patients. The symptom still improve, but the quantum of the improvement is much less compared to giving ICS LABA in regular basis. So in terms of symptom free, we only achieve about 46% of patients. Still, 56% of patients who use MAHSA therapy have to use only 56% of the patient really use reliever daily. The reason for this, I mentioned to you just now, patient under perceive their symptom. In MAHSA approach, the symptom should drive the use of the extra inhaled corticosteroid and LABA inhaler, but patient under perceive their symptom. Therefore, they are not using their reliever. Now let's compare between MAHSA therapy, budesonide maintenance and reliever therapy, and using a regular salmeterol fluticasone inhaler. So we can achieve good asthma symptom in almost 73% of the study population compared to MAHSA therapy only 44%. The patient require less reliever in regular ICS LABA inhaler. In contrast, those using MAHSA therapy, they require at least one extra reliever for per day. Better rescue-free days about 87%, in contrast only 56% in MAHSA therapy. And obviously, the lung function test is much better in those using ICS LABA combination on the regular basis. Okay, how about quality of life? So one of the questionnaire that we use to assess quality of life is Asthma Quality Life Questionnaire, or AQLQ. So in this questionnaire, in total there is 32 items that can be divided into 4 main categories: symptoms, activity limitation, function, emotional function, and environmental exposure. So for each domain, there will be score 1 to 7. The higher the score, 7, there is no impairment at all, and score of 1 indicates severe impairment. So in this study, it shows that. So in this study, there's 2 arms, give ICS LABA combination and ICS alone. Both arms is given on regular basis. So if we give preventer either ICS LABA combination or ICS alone on regular basis, we can achieve good asthma control in majority of the patient. So when we do the AQLQ, the score on average is more than 6. So more than 6 indicate minimal or no impairment of quality of life due to asthma. So good asthma control is possible if we give regular preventer to our patient. So in addition to whether to give regular basis or pair-end approach, we should consider other things as well in deciding our inhaler. One of it is whether patient have poor inhaler techniques. There is multi reason for the poor inhalation technique. I think Dr. Nickman already described yesterday. So how we choose which inhaler best for our patient? So this paper by Prof. Usmani summarize the algorithm how we should choose our inhaler. So in summary is ACT, asthma control test. So but ACT in this algorithm refer to A, assess, C, choose, T, train. So there are in terms of assessment, there are two types of inhalation technique. Number one is slow and steady, and patient should take slow, steady breath over 3 to 5 seconds. And the second technique is quick and deep inhalation. So patient should take quick deep breath within 2 to 3 seconds. So when I advise my patient for slow and steady technique, patient should inhale without any accessory muscle. So your sternocleidomastoid muscle, your intercostal should not be used in slow and steady breathing. But for quick and deep breathing, the accessory muscle should be used during the inhalation. Based on these two techniques, you can decide whether patient is suitable for metered dose inhaler or dry powder. Those who can perform slow and steady inhalation, this group of patient, they should prescribe with MDI or soft mist inhaler. Those able to perform quick and deep breathing, you can consider dry powder inhaler for this group of patient. Once you choose which type of inhaler suitable for your patient, then you should teach your patient how to use the inhaler correctly. It involves preparation of the inhaler, make sure the patient prime the inhaler, make sure the patient exhale fully in order to inhale fully, make sure the patient secure the inhaler tightly at the mouth. There's no teeth or tongue obstructing the inhaler, and based on the inhaler, then there is specific technique to do the inhalation, followed by breath holding, minimum 5 seconds to allow the particle to diffuse in the lung. And lastly, how to look after the inhaler. Okay, among the inhaler, the highest percentage or the commonest inhalers that have error is MDI, followed by turbohaler, nebulizer, and the least device that can cause critical error is HUiTM. The reason for MDI to cause a lot of incorrect technique is, you can see over here, the higher percentage trigger and simultaneously breathing. Coordination between activating the inhaler and breathing. That is the commonest error when patient using MDI. For turbohaler, you can see turbohaler, the commonest mistake, they should hold the inhaler upright. If the patient twists the turbohaler horizontally, the medication will not go to the inhaler chamber. So medication will not, when patient inhale, the medication is not there. And other thing, when you twist, you make sure the patient have click sound. So among the inhaler device, HUiTM is the least cause any critical error when using it. So it's very important. We should tailor the asthma treatment for each of our patient, because not all patients require same treatment, and they also will not behave in the same manner when receive the treatment. So whenever we decide any inhaler, we should know the efficacy and safety of the medication given. Please consider patient-related factor, disease-related factor, as well as device-related factor. If you try to use MAT therapy, bear in mind, patient have poor Patient have poor reception on asthma control, they tend to underestimate their symptoms. Some patients they overestimate their symptom. Okay, they think this is asthma. Maybe when we assess in detail, the symptom that patient suffer is not related to asthma. So when we use MAT approach, maintenance and reliability approach, there is possibility that patient underestimate or overestimate their symptom, which lead to underuse or overuse of their MAT therapy. So there is concern if we use long-acting beta agonist in asthma patient, you cause harm in asthma patient. So Australia study tried to look at the safety profile when we use ICS with LABA combination. So this study is over 26 weeks. There is 3 arms, 3 different doses of steroid. So we have the against similar dose of steroid. So we have the first arm is using salmeterol fluticasone at 100/50 micrograms, again fluticasone 100 milligram BD. Second arm at higher dose of steroid, fluticasone salmeterol fluticasone 50 to 50/50 against fluticasone 250, and the last arm even higher dose of steroid 50/50 against 50 microgram of fluticasone alone given PD. What does this study show? In terms of severe asthma-related event, where the patient require intubation, death, or hospitalization, there is no difference within the 2 arms. So giving long-acting beta agonist in combination with inhaled corticosteroid would not cause more harm to asthma patient. So it's safe. So my final message is, it's important to start early and timely initiation of inhaled corticosteroid, and we should give it in regular dosing to prevent airway remodeling. Hopefully, this will translate to better achievement of asthma control in our patient. That is my final slide. Thank you very much for your attention. Any question from the floor?